Good morning, everyone. The Subcommittee on Health will now come to order. Due to COVID-19, today's hearing is being held remotely as well as in person. For members and witnesses that are taking part in person, we're following the guidance of the CDC and the Office of the Attending Physician, so please wear a mask when you're not speaking. For members and witnesses taking part remotely, microphones will be set on mute to eliminate background noise, and you will need to unmute your microphone when you wish to speak. Since members are participating from different locations at today's hearing, recognition of members for questions will be in order of subcommittee seniority. Documents for the record should be sent to Megan Mullen at the email address we've provided your staffs, and all documents will be entered into the record at the conclusion of the hearing. The chair now recognizes herself for 5 minutes for an opening statement. Today, our subcommittee examines 12 bipartisan bills. There's some noise in the background. Can you maybe refrain or take your conversations out of the hearing room? Today, our subcommittee examines 12 bipartisan bills to improve the health care of the American people. 6 of the bills focus on children's health and well-being. Pediatric cancer is the #1 disease killer of children in America, but it is chronically underfunded by the public and private sectors. The Gabriella Miller Kids First Research Act 2.0 addresses this gap by redirecting hundreds of millions of dollars in penalties currently paid by pharmaceutical, cosmetic, supplement, and medical device companies into funding for a large-scale genetic and clinical database to help researchers find insights into childhood cancer. We're honored to hear testimony about this bill from Gabriella's mother, Ellen Miller. Thank you, Mrs. Miller, for joining us today, so close to the 8-year anniversary of Gabriella's death. And thank you for her beautiful portrait that you have at the table with you. Another children's health bill, the Children and Media Research Advancement Act, authorizes the NIH to lead research on the effects of technology and media on infants, children, and adolescents. We can't trust social media companies to do the right thing for our children. This bill provides funding for long overdue independent research to keep media and tech companies from evading scrutiny about their impact on the development of children in our country. The other 4 children's health bills seek to prevent and reduce the impact of stillbirth, newborn hearing loss, lead poisoning, and birth defects or anomalies. We're fortunate to have Stacy Stewart of the March of Dimes as our expert witness for these bills. For over 80 years, the March of Dimes has been a trusted advocate for the health of all moms and children in our country. The next 3 bills focus on screening and prevention for lung, breast, and prostate cancer. First, Katherine's Law. It provides free coverage of lung cancer screening for individuals over the age of 40, even if they have no history of smoking. Nearly 25% of all cancer deaths in the United States are due to lung cancer, and a growing share of lung cancer cases are occurring in never smokers. If lung cancer and never smokers were a separate category, it'd be in the top 10 cancers in our country for sickness and death. This tragedy hit home for one of our cherished colleagues, former Congressman Rick Nolan, who's with us today. He lost his precious daughter, Katherine, to lung cancer, even though she did not smoke. Thank you, Congressman Rick, for being here today. It's good to see you, and we look forward to hearing your all-important testimony. The PALS Act allows for the early detection of breast cancer through free screenings for women over the age of 40, and the Prostate Cancer Prevention Act funds CDC programs to prevent and detect prostate cancer, the second most common cancer among men in our country. Finally, we're considering two bills to improve cardiac care and a bill to improve oral health literacy. The Carroll Act is named in honor of Carol Leavell Barr, the wife of Representative Andy Barr, who died last year of sudden cardiac arrest. The bill funds NIH grants to support research into valvular heart disease, as well as increasing public education and awareness of valvular heart disease through the CDC. And the increasing access to quality cardiac rehabilitation care authorizes PAs, nurse practitioners, and clinical nurse specialists to supervise cardiac rehabilitation care so more Medicare patients can benefit from that care. Patients who receive cardiac rehab typically recover faster from heart attacks or surgery and improve their quality of life. Through our efforts today, these 12 important bipartisan health bills move closer from being words on a page to actually walking into the lives of our constituents to improve their health and well-being for decades to come. The chair now is pleased to recognize the gentleman, and that he is Mr. Guthrie, the ranking member of our subcommittee, for 5 minutes for his opening statement.
Thank you, Madam Chair, for hosting this important meeting, and welcome to my friend from Minnesota. I'll have you here and the rest of the panelists that are here with us today. Before us today are several public health bills pertaining to critical prevention and early detection efforts for children and families. But before I get into those bills, I'd like to draw attention to the partisan health policies currently being drafted by Democrats behind closed doors here in Washington. My colleagues on the other side of the aisle are trying to pass a reckless tax and spending spree package that would get the government more involved in Americans' lives, including their health care. The Democrats' bill will cost an estimated $4.3 trillion, and according to the Congressional Budget Office letter received yesterday, this bill would lead to 2.8 million Americans losing their employer-based health insurance. Further, this spending bill is a stepping stone for a government-run, one-size-fits-all healthcare system that could lead millions more losing their employer or union-sponsored health insurance along with their doctors. And I've been a longtime supporter of increasing health care access for patients and allowing patients to keep the doctor of their choice. I believe we need to modernize, personalize, and improve health care and not let the government take it over. That would lead to worse care, longer waits, and fewer choices. And further, I must bring up H.R. 3 that's in the spending bill that would stifle innovation for finding new cures and result in fewer new treatments. I strongly believe in investing in biomedical research to discover innovative solutions to prevent, detect, and treat disease. Innovation improves healthcare outcomes and saves lives. The drug pricing scheme would do the opposite and destroy innovation. But fortunately today, we're taking a step in the right direction by examining several important bipartisan public health initiatives. Since 2015, I've been proud to lead, along with my colleague, Representative Doris Matsui, the Early Hearing Detection Intervention Reauthorization Act, or EDI. This bipartisan bill would provide early diagnosis, intervention, and treatment of children with hearing loss. Nearly 3 out of every 1,000 children in the U.S. are born with a detectable level of hearing loss in one or both ears. Before the EDI program began 2 decades ago, only 46.5% of infants were screened for hearing loss. Thankfully, due to the success of the program, 98% of infants are now screened. However, follow-up treatments continue to be a concern, with only 67% of infants receiving early intervention treatment. It is essential that infants are screened early for hearing loss and receive necessary intervention services in a timely manner so families can get the appropriate care needed. Additionally, I'm honored to co-sponsor H.R. 1193, the Cardiovascular Advances in Research Opportunities Legacy Act, or CAROL Act. Despite having long been a supporter of legislation that promotes health research, these efforts became much more personal for Representative Andy Barr when he tragically lost his wife, who was 39, Carol, to sudden cardiac arrest in June of 2020. Inspired by her extraordinary life, and those who knew her, she was extraordinary, he introduced H.R. 1193, the Cardiovascular Advances in Research and Opportunities Legacy, or the CAROL Act. The CAROL Act will address the gaps in understanding about valvular heart disease by authorizing a grant program administered by the National Heart, Lung, and Blood Institute to support research on valvular heart disease, including MVP. The bill has garnered the support of 167 bipartisan members of Congress, including many on this committee. Companion legislation was introduced in the Senate by Minority Leader Mitch McConnell and Senator Kirsten Sinema. The legislation would help other families avoid the tragedy and has so profoundly impacted Andy's family and so many others throughout the country. In closing, we do have bipartisan and successful public health programs that should continue. Before Congress authorizes new programs, we need to ensure that current programs are impactful, funds are spent appropriately, and reform or improvements to a program are evaluated. We've learned time and time again that throwing money at a problem is not an effective way to solve issues or good use of taxpayer dollars. I'll yield back.
Gentleman yields back. The chair is pleased to recognize the chairman of the full committee, Mr. Pallone, for his 5 minutes of opening statement.
Thank you, Chairwoman Eshoo. Today, the committee continues our important bipartisan work to protect children and families. The COVID-19 pandemic has tested every aspect of family health and demonstrated how critical physical and social environmental factors are to health outcomes. There are also significant concerns that many children and families have gone without routine care during the pandemic. And this is worrisome because this care is critical to promoting public health and identifying health conditions early. Unfortunately, it will be some time before we realize the full impact of this lapse in care. Today, we're considering legislation that will tackle these challenges in multiple ways. For example, the pandemic created obstacles to preventative care, including cancer screenings, which could have resulted in early forms of cancer going undetected. We'll consider 3 bills that reauthorize or otherwise expand life-saving screening services for lung, prostate, and breast cancer. And these are important bipartisan pieces of legislation that will help Americans access care and treatment when it's most effective. The pandemic has also undoubtedly delayed care for children and introduced new challenges in the absence of childcare and in-person learning. Some studies suggest that nearly 30% of parents postponed or did not seek care for their children due to concerns about exposure to COVID-19. The impacts have been greater on lower-income families who have been more likely to delay care or to simply go without care. And since the pandemic has had a disparate impact on lower-income families, it's important that we act to reverse any harmful effect on the health and well-being of children. And today we are considering multiple bills that seek to expand pediatric research and healthcare services. We'll discuss H.R. 2161, the Children and Media Research Advancement Act, which will reauthorize the National Institutes of Health to expand research into the cognitive, physical, and social emotional development effects of media on infants, children, and adolescents. This bill is particularly important right now as the pandemic has resulted in children spending more time on electronics for learning and social engagement with friends. We'll also consider H.R. 5487, the Stillbirth Health Improvement and Education for Autumn Act. This bill would provide resources to state and federal health departments to improve data collection and increase education about stillbirths, which tragically affect an estimated 24,000 families nationwide each year. And these are just a few of the proposals that we'll consider, and we have an excellent panel of witnesses ready to discuss the full slate of bills. We'll hear from medical experts in the fields of cancer, cardiology, and pediatrics. And we'll also hear from 2 parents who will share the stories of their 2 daughters, Katherine Benson and Gabriella Miller, who both lost their lives too soon to cancer. I look forward to hearing from Ellen Miller, who's also the president and founder of the Smashing Walnuts Foundation, about the Gabriella Miller Kids First Research Act. And I would also like to thank our former colleague, Representative Nolan, for coming to share his daughter Katherine's story and to discuss the Katherine's Law for Lung Cancer Early Detection and Survival Act. Finally, I'm pleased we're able to work with Ranking Members Rodgers and Guthrie on this hearing and on this bipartisan slate of bills that will improve the health of children and families all across the nation. And I'd look forward, I know we're having these legislative hearings, but we look forward to moving these bills soon. So thank you, and I yield back, Chairwoman.
A gentleman yields back. The chair now is pleased to recognize Congresswoman Kathy McMorris Rodgers. Is she?
She's virtual.
She's virtual. Oh, okay, great. Congresswoman McMorris Rodgers is the ranking member of the full committee, and pleased to recognize her for her 5 minutes for an opening statement.
Thank you, Madam Chair, Mr. Chairman, and to all our witnesses. Thank you for being here this morning. Many of the solutions we're considering today renew key public health programs. For years, I've the importance of renewing and updating expired authorizations that continue to be appropriated. So I'm pleased that our members are fulfilling the duties we have as an authorizing committee. Mr. Carter's Improving the Health of Child Act reauthorizes activities at the National Center on Birth Defects and Developmental Disabilities. Mr. Wahlberg's Lead Poisoning Prevention Act renews critical lead poisoning prevention and screening initiatives. Dr. Dunn's bill reauthorizes prostate cancer activities at the CDC. Other bills reauthorize programs that expire next year, like Mr. Guthrie's Early Hearing Detection and Intervention Reauthorization Act. We'll also be considering bills that establish new public health programs, like Representative Nolan and Herrera Butler's Shine for Autumn Act to mitigate the risk of stillbirths and help more moms and babies. And Mr. Barr's Carroll Act that will improve research and public health outreach related to heart disease. All of these solutions reflect the importance of the committee's authorizing responsibilities over key public health programs. It's important for federal agencies to come before this committee to comment, discuss programs and other related health initiatives and that also should have happened today. In fact, except for a budget hearing with Secretary Becerra on the budget that was not released at the time, no administration official has come before the Health Subcommittee this Congress. We need to hear from the administration and public health officials. They have not been before this committee even after making top-down decisions that impact every person in this country related to COVID-19 data, changing guidelines, schools, vaccine mandates, and booster shots. Unfortunately, it's undermining trust in public health and people's abilities to make the best decisions for themselves. We're also seeing a historic surge in opioid overdose deaths, made worse by the economic shutdowns, lost jobs, isolation, fear, and despair. The majority's refusal to bring the administration before us to address these crises is a complete lack of our oversight and legislative responsibilities. We should be plowing the hard ground, listening and working together to crush this pandemic and modernize healthcare. The bills we're considering touch on several important issues, but we also must recognize the central role our public health programs have played over the last year and a half and the massive influx of funding that they've received as a part of the pandemic response. We should be addressing these public health agencies more holistically. Let's hear from states and substance abuse and mental health service administration on how to save lives, combat the opioid epidemic, and improve the mental health of children who are in crisis. Let's permanently schedule fentanyl analogs in Schedule 1. DEA is warning the American public on the increasing dangers of fake prescription pills containing fentanyl. Let's learn from the pandemic on how we safely speed up innovation, like we did to get safe and effective vaccines and apply those lessons to discover new cures and treatments. Let's investigate how this pandemic even started so it never happens again. This committee has a rich history of bipartisan work by listening and leading on solutions to solve our greatest challenges. Today is a step in that direction, but we have a lot more work to do to address the concerns that are on the hearts and minds of the American people. And this brings me to the tax and spending spree that Speaker Pelosi is rewriting right now behind closed doors. It will lead to fewer cures, lost coverage, and force the sick to beg the government for life-saving care. Just yesterday, CBO provided its analysis that shows the dangers of the majority's lurk to socialized medicine that's going to cost more than $500 billion. 2.8 million people will lose their employer-sponsored health care. Just like 11 years ago, Speaker Pelosi plans to pass a massive bill that radically disrupts people's lives and livelihoods. And if you like your health insurance, you may not be able to keep it. I again urge this committee to get back to the people's work, not the speaker's agenda, and take a step in the right direction today. I hope we can continue this encouraging trend by addressing the important major public health issues facing our nation today. Thank you. I yield back.
The gentlewoman yields back. I would just like to make a couple of comments. I always welcome constructive criticism. It's always welcome. We learn from each other. But the ranking member is not correct about testimony from administration officials. We've had the FDA, we've had the NIH, they were both in July. We've had the CDC, Dr. Collins, who testified on long COVID. There's no bill that's being written behind closed doors. All of the Energy and Commerce Committee were involved in, 36, 38, 39 hours of markup of the Build Back Better legislation. The Energy and Commerce Committee, of course, had a significant role in that. So I just want to state that for the record because those are the facts. I now would like to introduce our witnesses. We're so fortunate to have each one here today. First, our colleague, our former colleague, someone that will be a friend for life, Congressman Rick Nolan of Minnesota. He's the father of Katherine and the namesake of Katherine's Law, which we're considering today. Dr. Donald Lloyd Jones is the president of the American Heart Association. Welcome to you. To Ms. Stacy Stewart, the president and the CEO of the March of Dimes. When she came into the hearing room this morning, I went over to welcome her and told her what I recall as a child, maybe 7 years old, 8 years old, my mother holding my hand and walking through the entire neighborhood, ringing doorbells in the early evening after supper for donations to the March of Dimes. So that is not only etched in my memory, but it's etched in my heart. Dr. Jenny Radesky is the assistant professor of pediatrics at the University of Michigan Medical School and a constituent of Congresswoman Debbie Dingle. We'll call on Congresswoman Dingle to introduce Dr. Radesky. Dr. Bruce Cassis is the president of the Academy of General Dentistry. Dr. Raymond Dubois is the former president of the American Association for Cancer Research. And Ms. Ellen Miller is the president and founder of the Smashing Walnuts Foundation and the mother, most importantly, the mother of Gabriella Miller. So Congressman Nolan, we'll start with you. You're recognized for 5 minutes, and welcome again, and thank you for traveling across the country to be with us this morning. Is your microphone on, Rick?
There we go.
There you go.
Turn it towards you.
Oh, thank
And bring
you.
it toward you.
Thank you. It's such a joy.
And you can take off your mask while you're testifying. Yeah.
Pull your mic up.
And pull the mic up to you. There you go. See, just
Used
2
to
years
sitting on
and
the
you're,
other.
there you go.
Used
2
to
years
sitting on
and
the
you're out
other
of
side of the
practice.
table. It's such a joy to see so many old friends, and thank you for inviting me to be here today. As I was saying, Chairwoman Eshoo, Ranking Member Guthrie, Chairman of the full committee, Frank Pallone, and Representative McMorris Rodgers. And thank you all for being here. I'm here not as a former member. I'm really here as a father and a public citizen and a non-lobbyist for anybody, I might add, and to give testimony and to thank all of you on this committee, your personal staff, your committee staffs for their service, for conducting this hearing. for giving me an opportunity to testify on behalf of HR 3749, Catherine's Law, for the early detection and survival of lung cancer victims. A little history, it was in 1971 that President Richard Nixon declared war on cancer. And since that time, every president, Democrat and Republican, has entered into that war and joined with the Congress of the United States and this committee in a very strong, resolute, nonpartisan manner to win this war against cancer, which kills so many people. Lung cancer in particular, which kills more people than virtually all the other cancers combined. Our daughter, Katherine, who was a non-smoker, devoted her terminal cancer diagnosis as what she called her ticking time bomb. It was not a matter question of whether, it was just a question of when. And she chose to devote the last years of her life to her 4 children, her husband, and in doing everything she could to spare people in the future from having to endure what she and so many others had to endure. And it was during that process where Katherine learned and informed her dad that breast cancer, prostate cancer, colorectal cancer benefited from public policies that provided routine-free cancer screening, which enabled early detection. Unfortunately for lung cancer, the only people, and by the way, that was starting at age 40 for most of these other cancers. Unfortunately for lung cancer, the only people who were entitled to that routine screening were 55 years of age, and they had to have smoked a package of cigarettes every day for 20 years. Or was it 30 years? Somebody can correct me on that. I forget at the moment. But people who were non-smokers, many of whom are victims of lung cancer, were not entitled to any screening whatsoever. And she learned also, informed me and others, that was in part because of the stigmatization of lung cancer by virtue of smoking, but also the fact that our lungs don't have any nerves, unlike the other parts of our body. So in the other cancers, in addition to early detection and screening, you might feel a lump, you might feel discomfort, you might feel pain. That doesn't happen with lung cancer. There are no nerves. You don't have any discomfort until it starts pressing against other organs. And without the benefit of early screening, you're not getting the same strong positive results that the victims of other cancer have. Breast cancer, for example, prostate cancer, colorectal cancer, they respectively have survival rates after 5 years of 90%, prostate cancer 98%, colorectal 65%. Unfortunately for lung cancer, it's a little over 20% after 5 years because of that disparity. Very unfair to the victims of cancers, whether they were smokers or non-smokers. And during her journey, that's when we learned this. And so she said to me, Dad, is there any reason why we can't draft a bill to provide that same kind of opportunity for free screening for victims of lung cancer? Kills more people than all the other cancers. Why not do that? Give them an opportunity to survive with early detection. So that's how the bill emerged. And I've told you what the survival rates are. This bill gives each and every one of us here a chance to advance that. And as I said, it's always been a strong, nonpartisan, bipartisan effort that has resulted in those wonderfully good statistics for so many of the other cancers, but not for the victims of lung cancer. In any event, Katherine said, Dad, if that bill could be passed, I would gladly, along with endure all that I've had endured, along with so many others, gladly, including my fatality at the end, if I knew that it would spare so many other people the pain that we've had to endure. So the bill was drafted, and Congressman Brendan Boyle agreed to sponsor it and sponsor it in her name. And let me conclude with just a couple things here. Several hours before Catherine died, we, of course, were with her. And she was very weak. And I said to her, Catherine, one of the great mysteries, most will admit we don't know where we're going when this life of ours is over. But I said, wherever that is, I want to be there with you as soon as possible. And with her weak but clear voice, she just raised her hand. She looked her dad in the eye and said, Dad, not until you get my bill passed. So it's in that spirit that I'm here today. And I can't thank each and every one of you. So let me close by saying what that immortal Western cowboy hero of ours, John Wayne, who died of lung cancer, might have said. God willing, the creek don't rise, and the Congress enacts this important legislation. Catherine's law will become the law of the land, and many tens, if not hundreds of thousands, of lives will be saved. Thank you.
Thank you, Congressman Nolan. Catherine's law will become the law of the land. We're on our way. And you're being here to help launch it. And the work that we're doing today is we have a clear path, and we're going to make sure what Catherine said before she left this world becomes reality. How's that? Okay, thank you so much. Dr. Lloyd Jones, you're recognized for 5 minutes of testimony.
Good morning. Thank you. Can you hear me?
Good morning. Welcome.
Terrific. Thank you. Chairwoman Eshoo, Chair Pallone, Ranking Members Guthrie and McMorris-Rodgers, and members of the Health Subcommittee, thank you for the opportunity to testify today on behalf of the American Heart Association and its more than 40 million volunteers and supporters. My name is Dr. Donald Lloyd Jones, and as president of the American Heart Association, I serve as its chief volunteer officer responsible for the oversight of all medical, scientific, public health, and public policy matters. I'm also a cardiologist and a cardiovascular epidemiologist and chair of the Department of Preventive Medicine, professor of preventive medicine, cardiology, and pediatrics at Northwestern University's Feinberg School of Medicine in Chicago. I'm pleased to testify today about the ways in which two bipartisan bills under your consideration would improve heart health for all. Specifically, I wish to address the Increasing Access to Quality Cardiac Rehabilitation Care Act of 2021, HR 1956, and the Cardiovascular Advances in Research and Opportunities Legacy, or CAROL Act, HR 1193. My statement today is a summary of my more extensive remarks in support of these bills that have been submitted for the record. I'd like to thank Representatives Lisa Blunt-Rochester and Adrian Smith for championing the Increasing Access to Quality Cardiac Rehabilitation Care Act, which would significantly expand patient access to cardiac rehabilitation services. Cardiac rehabilitation, or cardiac rehab for short, is a medically supervised program for patients who have experienced a serious cardiac event or surgery. It includes monitored exercise training, education about heart-healthy lifestyles, and counseling to reduce stress. Participation in cardiac rehab has been shown to significantly reduce the risks of death and cardiovascular events, as well as result in decreased hospital readmissions. As a practicing cardiologist, I am an avid user of cardiac rehab for all of my qualifying patients, and those who participated routinely tell me that it teaches them about improving their heart health and what symptoms they need to pay attention to in the future, and crucially, that it restores their sense of well-being and their ability to trust their body as they return to normal life and activities. Despite these clear benefits of cardiac rehab, only 1/3 of all eligible patients and only 1/4 of Medicare patients will ever receive it. Barriers to participation include things like lack of referral, large disparities in referral patterns based on sex, race, ethnicity, socioeconomic position, and geography, and long wait times to enrollment. This act would improve health equity by facilitating the timely referral of patients and by enabling greater patient access in rural and underserved communities. It would also remove burdensome requirements for direct physician supervision at cardiac rehab facilities, where highly trained advanced practice providers are already able to provide necessary safety oversight. These advances will allow cardiac rehab programs to operate in areas where physicians are scarce, improving patient access to these life-saving programs. The American Heart Association is also pleased to support the Carroll Act. And first, I'd like to express my deepest sympathy to Representative Andy Barr and his family for the tragic loss of his wife, Carol. We're deeply grateful to him for sponsoring this legislation to advance our understanding and awareness of heart valve diseases that kill approximately 25,000 Americans each year. With this bill, we could help prevent more families from enduring a similar tragedy. The Carroll Act authorizes funding for the National Heart, Lung, and Blood Institute to gather information and fund life-saving research on heart valve disease. This investment will help address gaps in our understanding, including what causes sudden cardiac death due to mitral valve prolapse, or MVP. MVP is a degenerative heart valve condition that is present in approximately 2% of individuals, many of whom are unaware that they have it, and that led to the untimely death of Carol Barr. MVP uncommonly becomes a serious condition, but when it does, it can cause heart failure, stroke, or abnormal heart rhythms that may become life-threatening. Significant MVP poses a threefold elevated risk of sudden cardiac death compared to the general population. One of the most troubling aspects of MVP for me as a clinician is just how much we still don't know about its causes, factors that lead to progressive problems, when is the best time to intervene, and what increases risk for sudden cardiac death. The Carroll Act would authorize new workshops and research funded by the NIH, increase awareness through projects at the CDC, and invest in efforts to improve data collection about sudden cardiac arrest. Ultimately, it would increase screening, detection, and diagnosis of heart valve disease and help reduce the incidence of sudden cardiac death. So in conclusion, the bills under consideration today will advance equity by improving access to care for cardiac rehab, and will expand our understanding and treatment for heart valve diseases, including MVP. Thank you so much for the opportunity to offer my testimony, and I look forward to answering your questions.
Thank you, Dr. Lloyd-Jones, for your important and superb testimony. We appreciate you being with us. The chair now recognizes Ms. Stewart for your 5 minutes of testimony. And welcome again. It's great to see you.
Great to see you too. Thank you. And good morning, Chairwoman Eshoo and Ranking Member Guthrie and members of the Health Subcommittee. Thank you for the opportunity to testify today. I'm Stacey Stewart, and President and CEO of the March of Dimes. The March of Dimes' work is now more important than ever. Our nation is in the midst of a dire maternal and infant health crisis, which the pandemic has worsened. By improving the health of women before, during, and after pregnancy, we can improve outcomes for both mothers and for infants. But we have many public health challenges before us. The U.S. remains the most dangerous developed nation in the world in which to give birth. And it's even more dire for women and babies of color. Preterm birth is the second leading cause of infant mortality, which has slowly declined over the past few years. Yet still 2 babies die every single hour, and 2 women die from pregnancy complications every single day. This month, as we observe Pregnancy and Infant Loss Awareness Month, we know that 1 out of every 4 individuals and families' lives are affected by the death of their children during pregnancy, at birth, and in infancy. We must help these families by remembering their losses and working to better understand the causes of stillbirth, with the goal of lowering the stillbirth rate. We hope new efforts by the Biden administration and Congress will spur further action to address the maternal and infant health crisis that we face. However, we must continue to focus our attention on the other challenges facing us and utilize the tools we have to improve the health of children and families. To that end, March of Dimes supports the following legislation that's being considered by the subcommittee today. First, H.R. 5487, Stillbirth Health Improvement and Education for Autumn Act of 2021, or the SHINE for Autumn Act, would invest in research and data collection to better understand stillbirth in the U.S. This will allow us to better track and research stillbirths, find out who's impacted and the role disparities have in negatively impacting infant and parental health. Second, HR 5551, the Improving the Health of Children Act, would reauthorize the National Center for Birth Defects and Developmental Disabilities. The center's tracking and public health research systems help to identify causes of birth defects and find opportunities to prevent them. It also does critical work in researching developmental disabilities such as autism, addressing blood disorders that affect millions of people each year, and advancing health care for people with disabilities so they can stay well, active, and a part of the community. March of Dimes has partnered with the center to support research and prevention, promote birth defects prevalence data from states on our Parastats website, and we've led efforts to help reduce health-related stigma through our Beyond Labels initiative. We're also a strong supporter of the Surveillance for Emerging Threats to Mothers and Babies network. It's called SETNet, which we must scale nationally to have a complete picture through real-time clinical and survey data of how COVID-19 impacted care for mothers and babies. Third, HR 5552, the Lead Poisoning Prevention Act, would provide critical resources for educational outreach, for screenings and referrals, the CDC's Advisory Committee on Childhood Lead Poisoning Prevention, and help lead exposure before children are harmed. Children can be severely affected by lead's impact on brain and body development, with Black children nearly 3 times more likely than white children to have elevated blood lead levels. High levels of exposure before and during pregnancy can cause fertility problems, hypertension, delayed brain development, premature birth, low birth weight, and miscarriage. HR 5561, the Early Hearing Detection and Intervention Reauthorization Act. This act authorizes the Early Detection and Intervention Program for deaf and hard of hearing newborns and infants and young children. The program has dramatically increased the number of newborns screened annually, as we heard from Ranking Member Guthrie, from less than 10% to currently around 98%, which has significantly helped deaf and hard of hearing children begin learning speech and language in the first 6 months of life to develop better language skills. Chairwoman Eshoo and Ranking Member Guthrie, I want to say thank you for inviting me to be here. I was so moved by your story, Chairwoman, of your early involvement with March of Dimes, as I know that's been the case for many of you. Thank you for your attention today, for focusing on some of the nation's most critical public health challenges. We must continue to invest in programs in our toolbox, such as prevention and data collection and surveillance systems. Thank you so much.
Thank you, Ms. Stewart, and the entire team at March of Dimes. It is an organization that is trusted and respected by the American people. Thank you for your leadership. Next, we're going to have Dr. Radesky testify, and we're going to call on our colleague, a distinguished member of our subcommittee, Mrs. Dingle, to introduce Dr. Radesky, who is, of course, hails from Michigan, and she can tell you the rest. So, Debbie, are you out there?
Thank you. I am, Madam Chair. Can you hear me?
Okay, good to see you.
Good to see you. And it's good to see all of our witnesses, who, 2 of whom I've worked with closely for many years, and to see our dear friend Rick. But I'm really proud that we got a Go Blue presence in the house today. And that one of our witnesses, Dr. Jenny Radesky, is practicing developmental behavioral pediatrician and assistant professor of pediatrics at the University of Michigan Medical School. Her research focuses on the impact that digital media use and mobile technology has on children's health and behavior, as well as on parent-child interaction. She's a practicing pediatrician who has focused on psychosocial determinants of childhood development, and she's the lead author of the 2016 American Academy of Pediatrics Policy Statement on Digital Media Use in Early Childhood. Her research has been cited by many people, CBS, the New York Times, and other leading publications. We look forward to her testimony today on the CAMRA Act and her expertise as a researcher and clinician. Thank you very much, Madam Chair. I yield back and I have to close again with Go Blue.
Thank you so much, Representative Dingle. Can you hear me okay?
We
So
can,
good
and
morning,
welcome.
everyone. Thank you. I'm so happy to be here and like to thank Chairwoman Eshoo, Ranking Member Guthrie, and members of the Committee on Energy and Commerce's Subcommittee on Health for the invitation to speak today. I am a developmental behavioral pediatrician at U of M Medical School, where my NICHD funded research focuses on media, parenting, and child social emotional development. So my testimony today is in support of CAMRA, the Children and Media Research Advancement Act, and it represents my expertise as a pediatrician and researcher, not the views of University of Michigan. So I first want to preface my remarks by emphasizing that caring about children's relationships with digital media is not an emotional issue. It's highly practical. It's good public health. Digital media are some of the most universal, ubiquitous exposures children experience on a daily basis, and they're often designed by adults untrained in the curious and expansive ways that children experience the world. Consequently, digital design often focuses on monetization or engagement metrics and may not consider unintended negative consequences on society, in particular children. So parents have seen firsthand the way digital design can either support or frustrate their family's needs during the COVID-19 pandemic. For example, whether their child is learning new computer coding skills through a well-designed app, or is distracted from remote learning by YouTube videos, whether their family feels connected through video chat or divided by extreme social media posts. And new digital products are being adopted at an increasingly rapid pace. For example, Pokemon Go reached 50 million users in less than 3 weeks. And tech companies are investing millions of dollars in marketing and data analytics to engage child and teen users. Academic research on how these technologies impact our youth cannot keep up. We need the support of the NIH to carry out rigorous, independent research on children and media. In my expert opinion, there are several pressing gaps in scientific knowledge that would benefit from CAMRA's funding. First, we need more nuanced understanding of the day-to-day relationships between media and child well-being. Research studies on children and media have often relied on global ratings of how children use media, such as screen time, which is not detailed enough for the complex outcomes like mental health. We need study designs that follow children in their natural experiences, track their responses to the media they use and the media messages they consume, so we can uncover sources of resilience and vulnerability. Second, new measurement tools are needed. My research lab has created innovative methods with the support of NICHD for studying media use, like harnessing data streams already collected by smartphones to see which apps children are using and when. My work with Common Sense Media has generated new ways of collecting children's YouTube viewing histories to evaluate what types of content dominates this platform. Tech companies already collect troves of these types of data. However, researchers need more access so that we can truly characterize the positive and negative experiences that children have online. Third, we need to know more about children's differential susceptibility to media. Research usually examines children as homogeneous population, but we know that children have remarkable variability in their strengths, their challenges. Some children are more anxious, some are easygoing, while others are impulsive and reactive, and this likely determines which children will have problematic versus balanced relationships with media. CAMRA specifically calls for this type of research, focusing on individual differences and media use. Fourth, we need to understand more about the interplay between poverty, psychosocial stress, and media use. There are deep socioeconomic inequities in our country, and this is rarely addressed head-on in media research. But as we saw during COVID-19, structural factors play a strong role in how much media children use and their access to other opportunities. Finally, CAMRA is unique in that it envisions a sustained commitment to this field, which needs to keep up with the rapidly evolving technology around us. For example, we need to understand the impact of virtual reality or the algorithms that shape children's recommendation feeds or other understudied areas like online gambling. Sustained CAMRA research dollars would also train a new generation of scientists to use cutting-edge methods and then translate their findings for parents and policymakers. This is a crucial moment for funding research and children in media. There's a growing consensus that it is time to shift the scientific framework away from only asking what children and parents can do better to also asking what technology companies can change, whether in their designs or their business models, to promote child well-being. This digital ecosystem is relatively young, so there's much that can be done to redesign it, based in part on solid independent evidence generated through NIH funding. So I'm grateful for your time today, and I appreciate your consideration of the CAMRA bill.
Thank you very much, Dr. Radesky. We appreciate your testimony, this is an area that really cries out for study. So your testimony is on this legislation. The legislation itself, I think, is really badly needed, and I'm glad we're addressing it today. Next, we recognize Dr. Cassis to testify for 5 minutes. We welcome you and we thank you for being with us. And you're on.
Thank you, Chairwoman Eshoo, Ranking Member Guthrie, Chairman Pallone, Ranking Morris Rodgers, and members of the subcommittee.
Can you
Thank you so
speak
much
up, Doctor?
I certainly can. Thank
Wonderful.
you so much for the opportunity. Is that better?
It is much better. Thank you.
Okay. Thank you so much for this opportunity to speak with you today. My name is Dr. Bruce Cassis, and I'm a general dentist from Fayetteville, West Virginia. I'm also president of the Academy of General Dentistry, or AGD, which represents over 40,000 general dentists across the country. We exist to serve the needs of our members through continuing education and advocacy, which in turn better serves the needs and interests of our patients. I'm pleased to be here today to discuss legislation that would help improve the health of families and children, specifically HR 4555, the Oral Health Literacy and Awareness Act. Oral health literacy is the degree to which people have the capacity to obtain, process, and understand basic health information and services needed to make appropriate oral health decisions. As a dentist practicing in rural West Virginia for nearly 42 years, I've seen firsthand, more times than I can count, the effects of oral disease, especially on our most vulnerable population, our children. Many people are unaware that oral health is linked to overall health. Diseases related to oral health can cause so many negative things: pain, loss of school and work time, nutrition problems, emergency room visits, and even death. Oral disease does not stop at the mouth and teeth. Diabetes, low birth weight, even early onset Alzheimer's, and many more. Fortunately, most oral health related ailments can be prevented. Good oral health habits are especially important for expectant mothers, children, and young parents. Oral disease especially impacts children. Tooth decay is the most common chronic disease among school-age youth. Roughly 1 in 4 U.S. adults has at least one untreated cavity. Most oral health ailments can be avoided by increasing oral health literacy among all populations, with an emphasis on children to ensure that they develop and maintain healthy habits into adulthood. Folks need to complete regular dental visits to stay on top of their oral health. Unfortunately, the majority of Americans are not using the oral health care system. According to the latest data from HHS, 46% of the population had a dental visit in 2018. This is only 1.7% higher than the percentage of the population who visited the dentist in 2003. The lack of progress on this front is startling and cannot continue. Notably, significant disparities continue to exist within our population when it comes to both oral health care utilization and status. While 52% of non-Hispanic white people were able to visit a dental provider in 2018, only around 34% of those who are Hispanic and non-Hispanic Black saw a dentist in the same year. According to the CDC, nearly twice as many non-Hispanic, Black, or Mexican American adults have untreated cavities compared to other groups. Adults with less than a high school education are almost 3 times as likely to have untreated cavities as adults with at least some college education. These disparities highlight the need to focus on oral health literacy improvement within vulnerable populations. Fortunately, Representatives Cardenas and Bilrakis have introduced legislation, HR 4555, that would do just that. The Oral Health Literacy and Awareness Act would direct the ERISA to develop and test evidence-based oral health literacy strategies. These strategies aim to improve oral health care education, including education on preventing oral diseases such as early childhood and other caries, periodontal disease, and oral cancer. This multi-year initiative would focus specifically on children, pregnant women, parents, older adults, and people with disabilities, and of course, racial and ethnic minorities. The strategies ERISA uses would need to communicate with these populations in a language that resonates with them. While we are all aware of the brochures and broad messaging on the importance of oral health, there has never been a serious effort at the federal level to develop actual evidence and measure outcomes on oral health literacy messaging. I believe ERISA's work through this initiative to measure outcomes on the effectiveness of targeted oral health literacy strategies would be indispensable.
Dr. Cassis, you need to wrap up.
Yes. Okay. I want to end today by stressing the importance of recognizing oral health literacy as an integral part of national health policy. And I do greatly appreciate the subcommittee's recognition that oral health literacy is a priority. Thank you.
Thank you, Dr. Cassis, for your important testimony. Dr. Dubois, we want to thank you for testifying today, and you now have 5 minutes to do so.
Can you hear me okay?
Yes.
Okay, great. Well, Chairman SU and Chair Pallone, ranking members Guthrie and Rodgers, and members of the subcommittee, thank you for inviting me today. I'm Ray Dubois. I'm the past president of the American Association for Cancer Research. I'm editor-in-chief of the Cancer Prevention Research Journal and director of the Hollings Cancer Center here in Charleston, South Carolina. I really commend you for this hearing and holding it to discuss important prevention for public health, and I'm very pleased you're including cancer screenings as a part of these discussions, and we've heard some very important testimony earlier. The data show that cancer screenings do save lives and improve outcomes because cancers, or in some cases precancers, can be identified at an earlier stage when physicians can treat it much more effectively. This often results in less invasive treatment, quicker recovery, and lower cost. Cancer organizations such as AACR publish research that informs the medical community about who, how, and how to most effectively screen for different types of cancer. We really want to avoid those false negatives and false positives and really have the most sensitive and specific screening possible. The U.S. Preventive Services Task Force, or USPSTF, examines the evidence of trying to lower cancer mortality, as well as risk, cost, and other complications. They grade the guidelines based on an A or B, and the Affordable Cares Act uses those tools, the A or B, so that those screenings can be covered by insurance without cost to the patient. As more research is generated, those guidelines can be updated. This year, they did update the eligibility for lung cancer and colon cancer screenings For lung, as you heard earlier, they changed the lung cancer deaths by 24% after 10 years by expanding screening to smokers as young as 50 who smoked a pack a day for 20 years. That doubled the number of individuals who could now be screened at no cost. Previously, only older Americans could be screened. These new guidelines are especially beneficial for women and African Americans who tend to smoke fewer cigarettes. The task force also reduced the age recommendation for colonoscopies from 50 to 45 because of the increasing incidence of that disease in the younger population. I am of the belief that effective screening is extremely important. However, that does not mean that screening for all cancers without a scientific basis is in the public interest. Overscreening can be cost prohibitive and sometimes with side effects. The task force has to balance this evidence with risk and benefits and be mindful that those recommendations are based on evolving science. Colon cancer screenings do not take into account the growing evidence that the younger obese Americans are being diagnosed with colon cancer at a growing rate. For lung cancer, it's based on smoking history and age, but it does not take into account whether a person grew up in a home with smokers or may have substantial interactions with secondhand smoke or increased risk due to occupation and environmental factors. The recommendation to start mammograms for women at age 50 will leave many younger women vulnerable to breast cancer that could spread before it could have been detected. In some cases, I would encourage Congress to consider the individual rather than the population as a whole when designing these screening criteria. There are many other factors besides just age, including underserved populations, occupation, environmental exposures, and lifestyle factors. The simple age criteria contribute to inequities, especially in the underserved communities who are underrepresented in screening trials and don't usually participate in those studies. And we want to ensure that all racial and ethnic groups and socioeconomic classes have the knowledge to make informed decisions. In South Carolina, the incidence of breast cancer in Black women is lower than that in white women, but their death rate is much higher because many Black women have longer delays to get screened and treated, possibly due to their access of care to health services. The mortality rate in prostate cancer for Black men is much worse than white men. While it could be genetic influences, it is most likely due to lack of access to specialty care. Screening and treatment outcome disparities are areas that the medical research community must improve on as we go forward. Many cancers we don't have effective screening mechanisms for at the current time. In addition to the advances in healthcare delivery, the congressional investment in basic and translational research is very important. Several academic institutions and industry are making progress in pan-cancer blood testing, which will bring new and innovative ways to screen for these cancers once they're validated and studied in large populations. Before I conclude, I want to importantly note that we are still not yet out of the pandemic, and we have lowered cancers screening for all cancers during this time. The NCI estimates that due to COVID-19 and delaying cancer screenings, as many as 10,000 additional Americans could die of breast or colon cancer in the coming decade alone. As the scientific community works to improve cancer screening, it's imperative that we really improve our screening in this process. I want to thank you again for the opportunity to testify before you today.
Thank you very much, Dr. Dubois, for your important testimony. There was so much packed into it with the statistics, and it's a reminder to all of us how important witnesses are, the expertise they bring to us, and obviously shoring up the reasons why the legislation we're considering should become law for the people of our country. So thank you. Last and certainly not least is Ms. Ellen Miller. Welcome again to you. Thank you for traveling and being with us in person today. You're now recognized for your testimony.
Thank you. Chairwoman Eshoo, Ranking Member Guthrie's, and distinguished members of this committee. My name is Ellen Miller, and I would like to thank you for the opportunity to testify in support of this childhood cancer and disease legislation, the Gabriella Miller Kids First 2.0. My daughter was only 9 years old when she was diagnosed with a terminal upon diagnosis brain cancer called diffuse intrinsic pontine glioma. This is the same brain cancer that Neil Armstrong's daughter, Karen, died from in 1962. 60 years later, and our children that are diagnosed with this cancer are still receiving the exact same treatment. But yet, in these 60 years, we've gotten men to the moon and safely back home. We have a rover on Mars, but we can't solve something that's a few inches under our skin. In the 80s, AIDS was a death sentence. Today, it's a chronic disease. A handful of years ago, Ebola was also a death sentence. Now it's curable. We as a country can claim these incredible accomplishments because we banded together to make them a national priority. In 6 days from now, on October 26th, will mark 8 years since my daughter died. In those 8 years, daily incidences of childhood cancer diagnoses in the United States has risen from 36 to 47. And every day, at least 7 kids die from cancer. This means that in those 8 years since my daughter died, over 137,000 parents have heard the words, "Your child has cancer." And more than 20,000 families have buried their child. We must make our children a national priority, and we have the vehicle to do that with the Kids First 2.0. The original Kids First was signed into law with strong bipartisan support in 2014. Many of those members are in this room right now, and it's because of your support that over 60 grants have been awarded to institutes across the country to research childhood cancer and birth defects. The Kids First program has generated the largest molecular and clinical data sets with approximately 50,000 genetic sequences that are publicly available to researchers across the country. Resources are brought together to develop new connectivity that allows for real-time data availability. All the while, this program is developing and implementing a transformative infrastructure that NIH has embraced and is using as a template across the institutes. The Kids First was selected to lead a development of new technologies that will empower the use of electronic health records. Its infrastructure is being used for a model for developing and piloting programs that focus on Down syndrome, rare disease, the Childhood Cancer Data Initiative, and more. It was also chosen to lead the development of the pediatric COVID clinical trial via the NIH Caring for Children with COVID initiative. The Kids First has opened the door in a transformative force within NIH and around the world, and it's just the beginning. I reached out to my Congresswoman, Jennifer Wexton, with the need to continue the work of the Kids First. She suggested an innovative funding source that Congress has used in the past, the use of existing non-designated penalties against bad actors that knowingly violate the Foreign Corrupt Practices Act. The Kids First 2.0 proposes to use this untapped resource from pharmaceuticals, medical device manufacturers, cosmetics, and natural supplements to continue the battle against childhood cancer and disease. To date, 77 bipartisan members agree, 22 of whom are members of the Energy and Commerce Committee. 2 weeks before Gabriella died, she was interviewed and asked what message she had for our elected official about kids like her, and she responded, "Stop talking and start doing." Our political leaders have certainly done that, and today I am personally asking the committee to continue doing by proceeding through markup and moving this critical piece of legislation to the floor as quickly as possible. My daughter's name might be on this legislation, but truth be told, it could be any number of the hundreds of thousands of children that are afflicted with cancer and disease across this country. And I bring with me today almost 1,000 families that have signed on because they wanted their children to be represented here today, and it could be one of them. I thank you for your time, and I look forward to your questions.
Thank you so much, Ellen. Your voice is an eloquent one as a mother. And thank you for representing all the other families that have lost their child. There simply cannot be a greater grief than for a parent to bury their child. It's not the way it's supposed to be, but we can do something about it, and that's what we're here for today. Thank you. To our former colleague and friend, Rick Nolan. Rick, you have really taught us all something. I never knew that lung cancer patients that never smoked got lung cancer. And I think that you've been a great teacher in that. And can you just for a moment tell us when, I'm recognizing myself now for questions, that when was your daughter diagnosed and how? Did she have any symptoms or was it? Yeah, turn your mic on.
Thank you. That's a very good question. My aunt Eleanor Nolan, the first female judge in the state of Minnesota, by the way, a real pioneer, was a half a century ago was diagnosed with terminal lung cancer, and she died 6 months later. Katherine was diagnosed a little over just about 6 years ago. But because of the great progress that's been made by this committee and people in the past. By the way, I like to remind people that in my grandfather's time, the life expectancy in this country was 47.
Right.
47. Today, because of
We'd all be
good
dead and
public
gone,
health
right.
policies, bipartisan policies, it's in the middle to upper.
So how did she find out that she had it?
Well,
did she not feel well?
Because, as I mentioned, the lungs don't have nerves, which is why early detection is so important. You don't find out.
But how
till
did
you're-
she find out, Rick?
You're
I
down.
have some other
You're out of
questions.
breath. You're out of breath.
I see, okay.
At which point,
All right.
it's too late. It's terminal. You didn't get those early indications. You didn't get the benefit of the early screening.
Okay,
and it's
that's
too late.
instructive. That's instructive. Ellen, to you, in the funds that come out of the penalties that are paid that you referenced, what amounts are those on average annually? About how much are we talking about?
I would love to be able to say a number with that. The challenge that comes into play is that you need to have somebody who's violating law. They have to be.
No, I was just curious if you know how much that is, approximately what goes into that fund.
I would love to be able to answer that. I could
Maybe we'll
get
find
you
out from
information
the,
and share
from the
that.
authors.
Share that with Aislinn about those that are in the past, but moving forward, it's impossible to say that.
Maybe, I don't know, does the staff on either side of the aisle know? If it's hundreds of millions of dollars, well, then that funding is going to be, those dollars are going to dance, I think, if it's hundreds of millions of dollars. To Dr. Radesky, Facebook research that was shared by the most recent whistleblower, Frances Hogan, demonstrated that 32% of teen girls said that they felt bad about their bodies, and Instagram made them feel even worse. I think that this is astonishing. I mean, it just takes my breath away. What's the difference, in your view, between internal company research and the type of research that the CAMRA Act would enable?
There are several differences. First, with academic or independent research, we have to go through rigorous training in protecting vulnerable populations, the IOB and ethical board approval, there's lots of transparency and lots of accountability in terms of reporting negative side effects or unintended events that might happen during our research. And I see the internal research from Facebook revealed some of those negative and likely unintended consequences of the design of Instagram, which is very focused on appearance and filters and other ways of editing images. But they didn't have the accountability to either stop their research, change their intervention, their product, or to be accountable to the users who were involved.
Have you ever been asked by a social media platform to provide any guidance to them?
I have communicated with several different teams. Facebook had reached out to me a few years ago. There's been invitation to conferences or more informal conversations with the child policy and safety teams at these companies. But I do not have a formal role with any of them.
Thank you very much. The chair now recognizes Mr. Guthrie, our ranking member of the subcommittee, for his 5 minutes of questions.
Thanks, Madam Chair, and thank for all of you being in this important meeting. And I'm just going to say I'm going to step out in a few minutes, not because I don't find this extremely important. I have a World War II vet and a couple other veterans that are going to be arriving at the World War II Memorial. I'm going to see them and I'll come right back. I want to greet them because this is very important to do. First, Rick, thanks for sharing your story. It's important. That's how our loved ones live on. We share their stories and move forward. Also, Ms. Miller, I had back in the early 70s, when I was probably 10 or 11, I had a friend of mine that had leukemia, Tam Hambach. That's how they live, by mentioning their names. And I always think she would could be alive today if we knew what if we moved forward with leukemia. And I had a good friend of mine, Abby Cummings, her mom, BJ Cummings, a friend of mine, was 11 in 2006, was diagnosed with bone cancer, I guess, and passed away a couple years later. And it's just like, can we not fix that? It's just a frustrating thing with so much, as you mentioned, going on. And I would tell you, there's nothing more bipartisan in Washington, D. As you see, if you watch the new cable news particularly, you think everybody's fighting over everything, but we're trying to figure out how to do more for NIH and cancer research, and just trying to find the right way to do that, and so appreciate it. And Ms. Stewart, I enjoyed talking to you the other day. Atlanta was the city we would go to when I was a kid, and we shared some experiences of growing up. My dad was the only one we never flew. We couldn't afford to fly, but he took us to the airport to watch planes take off and land. And I found out your father did as well, so maybe we're not that unique. But I have a question on the early childhood hearing. I only have a couple of questions, and I've used some of my time, so I wish I could ask everybody a question. But I've been a long-term champion on the early childhood detection. And as we saw, 98% of the kids now have early detection of everything. If we can catch it early, we can treat it, hopefully, and children can develop further. But we're having 98% get screened, but only 67.5% getting the care that they need as a result of the screening. And what, in your opinion, how can we reduce barriers to access?
Well, I think that your point is well taken in that we've made a lot of progress with early identification. But the issue is to go further than that, to not only identify it early, but to make sure that kids have the right access to the care, the referrals that they need, the services that they need. And we know that, for example, when kids are not able to identify hearing challenges early in life, it affects them. It affects them over their lifetime. It affects their early progress with early education. It affects their ability to succeed later in life. I think part of it is just making sure that both kids have access to the right referrals and the right services to follow up with, and that their families have the right education and awareness to know how their children can be treated as well. You know, parents have a big role to play in this, along with pediatricians, with early child care providers. We have to make sure that everyone is aware of hearing challenges and making sure that those kids have the right access to early identification, and then referral and services as well. And that may need to continue over a lifetime, not just early in life. Of course, we know that the earlier that those problems can be identified, even within the first month or two of life, that can make a big difference.
Right.
But we may need to provide services over a longer period of time to the extent that children have continued challenges.
Thank you for that. Thank you for the work the March of Dimes is doing for that. I think a lot of us know where we were when we got the phone call that my colleague Andy Barr's wife had passed away. Just tragic. And people get those phone calls every day, all the time. And so the Carol Act is before. So Dr. Lloyd Jones, you discussed in your testimony that some individuals are born with genetic risk for developing mitral valve prolapse, or MVP. The CAROL Act improves research that would help medical professionals detect the existence of this genetic risk and diagnose it early on. What are the main barriers hindering medical professionals from being able to improve detection methods?
Well, thanks very much for your question, sir. You're absolutely right. Mitral valve prolapse is one of the heart conditions that can run in families. There are other connective tissue diseases and other considerations that can lead to an increased propensity for mitral valve prolapse. But unfortunately, there's really no great way to diagnose this. Symptoms, as with lung cancer, only occur very late in the process. So we need people to have access to healthcare so we can listen to their chest with a stethoscope, which is probably the main way we start to become suspicious about mitral valve prolapse. But you can't diagnose this without echocardiography. And so that's really our main way. And once again, access to healthcare and quality healthcare are major issues for people in order to be able to be diagnosed and then monitored over time, which is a crucial portion.
Doctor, what did you say was needed to diagnose? I couldn't hear you, and I think it's important to know this.
Yeah. So the firm diagnosis of mitral prolapse requires echocardiography or ultrasound of the heart.
I see.
Yeah, in order to actually make the diagnosis. And it's the main way we monitor patients as well to see if that's progressing over time.
Yeah, I think Carol actually had been screened and was scheduled for one, and because it wasn't deemed critical, as critical at the time because of COVID, she couldn't get the service before that. She passed away from that, unfortunately.
So sad.
So I just want to, I know my time's expired, but I have a statement from Congressman Barr on his bill to introduce to the record, and then also American Speech Language Hearing Association statement. I think it's been given to the staff, and I'd like to introduce those to the record.
The gentleman yields back. The chair now recognizes the chairman of the full committee, Mr. Pallone, for his 5 minutes of questions. Thank you, Mr. Guthrie.
Thank you, Madam Chair. I want to emphasize that prioritizing robust funding in these key children's prevention, research, and screening programs really is critical in protecting the most vulnerable from long-term poor health outcomes. But I think the levels at which we authorize these programs matter and speak to the success and confidence and work of these programs and their policies. So my questions are all of Ms. Stewart. I know the March of Dimes is at the front lines of supporting the ED program and how these investments, probably know well how these investments can help improve health outcomes. So my first question is, in your view, is the level of the authorization in the reauthorization of the ED program sufficient to support the program needs and services as many families as possible? And if not, what authorization level do you think is necessary to ensure sufficient support?
Thank you. I think, I think the most important thing is making sure that we can reach as many kids as possible. And I think what we're asking for in terms of reauthorization is probably sufficient. I think the other thing, though, is, the fact of the matter is we still have a number of kids who are still being impacted by this issue, and they are suffering for a long period of time. I think one of the most important things we can do is to make sure that the amount of funding over a long period of time is available. For example, if they're screening early on, making sure that those resources are available so that they do have the kind of support that they may need over a longer period of time. A lot of families also need more support as well. So I think the reauthorization amount is probably sufficient, but I think we ought to continue to revisit to see what more may be needed over time.
All right, and then I have the same question for the level of support for the National Center for Birth Defects and Developmental Disabilities. Do you think the proposed authorization that's included in that bill, HR 5487, is sufficient to support the program? Same question.
Well, I think obviously the National Center has done some great work in a number of areas around birth defects, looking at blood disorders. We've been working with the center for a number of years on a number of these issues. I think one of the things that we have to better understand, for example, during COVID-19 is what is the effect that is having on families and on children today. So one of the things that we don't know right now is what more will we learn over time that we might need to invest more in later on. For example, what is the long-term effect of babies that may have been affected by COVID? What are their long-term effects that children may be affected by that we still don't understand today? So I think we need to, again, look at refunding where we are today, but be prepared that we may need to put more money into this,
No,
into the center going forward.
No, and I agree with you, but I mean, as far as the bill, you're okay with it at this point? You think it's adequate?
We are for what's being requested.
Because I wanted to ask you one more question about health inequities. These health inequities were brought to light as a result of the pandemic, even more so. And many of those on the front lines of intervention and screening programs have been raising these issues for years. But do you see health inequities as a concern in early intervention and screening programs such as ED? And should this committee consider more detailed guidance encouraging the expansion of work in this program to address disparities in follow-up services among racial or ethnic minorities or other medically underserved populations? My last question.
So Congressman, in just about every one of the issues that I've addressed today, starting from the broadest level of maternal and infant health all the way down to issues around lead poisoning or around other issues, generally around health inequity, this country faces those challenges across the board. It's very clear that we have underinvested and we've not had the kind of policy environment that really supports making sure there's an equal playing field with respect to health equity. We know that Black women, for example, are 3 to 4 times more likely to die as a result of pregnancy and childbirth. Black women are 50% more likely to give birth to a baby preterm. Black women are far more likely to have a baby born stillbirth. So the fact that we have all these statistics really suggests that we are underinvesting, to your point, in eliminating health inequity. But it's going to have to be a much more comprehensive approach. There's one big effort that we're supporting right now around Momnibus, for example, that is intended to address those issues. But even in some of the issues that we're dealing with today, it's an issue that we have to continue to focus on because the health inequities are there, and we have historically underinvested in all of these areas.
I appreciate that. And let me just say, we are still pushing very hard for the Momnibus in
yes.
the reconciliation.
Appreciate that. Thank you.
Thank you. Thank you, Madam Chair.
Certainly. And Mr. Chairman, can you give our witnesses, especially the parents that are here, some indication when you think we can bring these bills to the full committee and then to the floor? He's going to kill me for doing
Well,
this.
as you know,
But I want you to leave
as
with
the
a lot of hope
chairwoman-
in your hearts.
As the chairwoman knows, we wouldn't be having this legislative hearing today if we weren't trying to move these bills soon, believe me. So, I mean, the answer is yes, that I'm not sure I know exactly what she asked me, but the answer is
Yes,
yes.
you
We
do.
want to move these bills soon. Thank you. I just
Okay.
have to rush to another meeting. I apologize.
Well, I just wanted to get you before you left. How's that? Thank you, Mr. Chairman. Okay, now I'm pleased to recognize the gentlewoman who is the ranking member of the full committee, Congresswoman Kathy McMorris Rodgers, for your 5 minutes of questions.
Thank you, Madam Chair. And to all our witnesses, I just want to thank you for joining us today. We've heard some really compelling, powerful testimony. Mr. Nolan, on behalf of Catherine's Law, it's good to see you, and thank you for sharing her story again. And to Mrs. Miller, I remember when Gabriella Miller Act was first passed, and just appreciate everyone for being here and advocating for so many others. And certainly Carol Barr's death was so untimely and hit us all really hard. And I appreciate the work that's being done to help others that may face similar situations. I've been very clear about my concerns with big tech, and I'm troubled by big tech censorship of conservatives and anyone that seems to disagree with liberal ideology. I believe that free speech is fundamental to our great nation. We need to cherish it, defend it, not attack it. I'm also very concerned about the harm that big tech is doing to our children. And we've seen it recently again with Instagram, but they're not alone. The same applies to TikTok, YouTube, Snapchat, any platform that profits from keeping our children online as much as possible. And that's why the Energy and Commerce Republicans are committed to leading this fight against big tech. And in fact, in July, every Republican on this committee rolled out a bill as a part of a larger package to address censorship and provide protection for our kids. Dr. Radesky, I've been calling on big tech to be more transparent about the impact that their products are having on children's mental health. And studies have shown that even passively consuming content is harmful. And yet these companies continue to design their products to increase this passive consumption. I just wanted to start by asking you, what advice do you give to parents as they consider their children's own use of social media?
Yeah, thanks for that question. And yeah, I work a lot with the American Academy of Pediatrics on guidelines to help families adapt to this rapidly changing tech environment that's often hard to understand. So the guidance we give is to be as curious and open-minded as possible, gather all the information you can, use resources like Common Sense Media, be as extremely informed, because right now the tech environment it still feels like a Wild West. It feels a little bit like a circus. They're trying to get lots of attention. There's a lot of good stuff out there, but in our research on YouTube, we found that the videos with the highest views, the ones that are getting the most reach through algorithms, are the ones that are actually the most shallow or the most consumerist, or they have some pranking and other sort of role modeling that we don't necessarily want kids to be, spending all their time with. So we encourage parents to watch along and help their children recognize when there's bad information or stereotypes or other sorts of messages that they don't agree with, and to help their kids be savvy, critical consumers, how to find the right sort of channels to subscribe to, how to take breaks from social media so you can reflect and see how it makes you feel. Our emotional and social reactions to these social media platforms that are often constructed to really get a lot of our attention around social relationships, it can happen without us truly thinking about it. It's supposed to be frictionless so that we're not pausing and reflecting on why we have these relationships. So that's another thing, is I encourage parents to take breaks, have experiments, open the conversation with their children to really help them guide through.
What would you speak to how you believe COVID-19 pandemic, distance learning, social isolation has also impacted kids' social media use and the increase of mental health issues?
Yes, this is such an important issue. And even yesterday, the AAP, together with other organizations, released a state of emergency on child mental health. We've seen a large increase in emergency room visits for mental health issues. In my own clinical practice, children have really suffered. School is very stabilizing for children, and the experience of remote learning resulted in decreased motivation, decreased sense of connection, more mood symptoms, sleep disruption, defiant behavior, or withdrawn behavior. This has been shown in multiple studies, and in our own research at Michigan, we have found that parents of elementary school kids said they started social media accounts for their children younger than they hoped to, just so they could keep in touch. So this is an extremely pressing issue, because children now have much more access to digital platforms that weren't necessarily designed with young minds in mind. And so what we have found is that in some cases, digital connections such as video chatting has helped child mental health, whereas more online gaming, lots of video viewing, less sleep isn't as supportive. And this is why both research and policy on this area right now is equally pressing.
Well, thank you for sharing your expertise.
Okay, who's next?
Mental health, the suicide crisis, and rest. I yield back, Madam Chair.
Thank you.
And thank you, Kathy. And we're all saying our prayers that your children are healthy and well very soon. We miss having you here in person, but want you to know that we're all thinking about you. The chair now recognizes the gentleman from North Carolina, Mr. Butterfield, for his 5 minutes of questions.
Thank you, Madam Chair. Let me first say good afternoon to all of my colleagues, and thank you, Madam Chair, for convening this very important hearing. And thank you to the witnesses. I've listened to all of your powerful testimonies, and just thank you for coming forward today and giving us the benefit of this information. Let me address my comment and my question to Ms. Stewart. Ms. Stewart, in your opening remarks, you mentioned how critical SETNet at the National Center for Birth Defects and Developmental Disabilities is to protect vulnerable mothers and babies. Can you expand more on this program's importance, both the reauthorization of the center as well as increased and sustained funding?
Thank you, Congressman. And I did mention about SetNet, and I just want to say a couple more things about it. What SetNet is really an innovative data collection system that links maternal exposures during pregnancy to health outcomes for babies. What we found, especially during the Zika outbreak, is that SetNet came in as a very useful system that allowed us to leverage existing data sources, enabling CDC and health departments to detect new and emerging health threats, to understand that health threat. We also know that in fiscal year 21, SetNet has provided support to 29 state, local, and territorial health departments to monitor impact on pregnant individuals and babies' exposure to Zika, to syphilis, to COVID-19. So what we know is that when we have better data collection, we can monitor these kinds of outbreaks more successfully, and we can create the right interventions. The most important thing, though, is that SetNet in fiscal year 21 was funded at $10 million. The House proposed increasing funding to, by another $5 million, but we still think that that's woefully inadequate to really get to the high-quality data collection system that we need. We've actually recommended that SetNet be funded at $100 million. And what we know is, especially as we're still dealing with the pandemic, the lack of data to really understand the impact and what's going on with pregnant women, and with children is affecting our ability to serve them and keep them healthy. So we would ask for that to be certainly reconsidered. And that goes back to the earlier question as well.
Let's just drill down if we can on data collection. I believe that data collection is just critically important for making a positive impact on maternal and child health outcomes. You may know that 2 weeks ago, the Communications and Technology Subcommittee held a hearing on my bill, which is referred to as H.R. 1218, the Data Mapping to Save Moms Act of 2021. The bill would require the FCC to map areas of the country that have both high rates of negative maternal health outcomes and gaps in internet service. It would also require the GAO to issue a report on the effectiveness of internet connectivity in reducing maternal morbidity rates. Can you now discuss how broadband and telehealth access will intersect with maternal and infant health?
Yes, and we are a proud supporter of the March of Dimes of the Data Mapping to Save Lives Act. We also saw during the pandemic how many pregnant women, for example, went without prenatal care because they were too concerned about getting out to their healthcare provider to seek care. We also know, for example, in this country, we have half of all the counties in this country lack basic access to obstetric care. And so if we don't have the ability for women to seek care through other means, especially through technology, through digital tools, we're still going to be leaving too many women without the care that they need, especially in rural areas. So this Data Mapping to Save Lives Act is really important to bridge the gap, to make sure we have technology available for women who may not be able to seek services close to where they live. And we would also want to make sure, and we support the provision that the GAO provide a report on the effectiveness of internet connectivity in reducing maternal morbidity rates as well. So thank you for your leadership on that.
And thank you for including those comments in the record. That's very important, and we're going to act accordingly. Madam Chair, before yielding back, let me just ask that we consider additional legislative hearings. I encourage the subcommittee to take up the Bill H.R. 2356, the Better Wound Care at Home Act, which I jointly introduced with Congressman Mark Wayne Mullen. This bipartisan bill will help patients with chronic wounds stay healthy in their homes and avoid future complications, particularly for patients of color who are at higher risk for infection, hospitalization, and limb loss. I thank the chair for listening. I thank you for your consideration. Thank you for your friendship. And at this time, I yield back the balance of my time.
You are such a gentleman, Mr. Butterfield, and a friend to all of us. Truth be told, I would have a hearing every single day of the week. I really would. So I think you need to nudge a little bit at the top of our committee. I certainly will. There are so many bills pending. This subcommittee is really the workhorse of Energy and Commerce in terms of subcommittees. We have some 700 bills, over 700 bills that have been referred to us, but it doesn't mean that we've taken them up. So I'm all for a crowded calendar. How's that? and I'd love to take your bill up. So let's talk some more about it. Talk to Mr. Pallone, and I would like more hearing dates for the rest of the fall so that we can really put the pedal to the metal and move a lot more legislation. A lot of good bills, a lot of good ideas, worthy ideas that are going to help people in our country. So thank you, Mr. Butterfield. Next, it's a pleasure to recognize the gentleman from Michigan. He is indeed a gentleman, and he's the former chairman of the Energy and Commerce Committee. Mr. Upton, for your 5 minutes of questions.
Well, thank you, Madam Chair. And Ms. Miller, it is nice to see you again. As I recall, I managed the time on the House floor debate with you and your daughter in the gallery a number of years ago, and was glad to shepherd that bill through and get it signed into law. And I've asked the co-sponsor the bill that you referenced today, H.R. 623. And Rick, it's always a pleasure to see you, even though you have a mask on. Mine was on a moment ago. But I'm going to help you keep your promise, and I'm going to co-sponsor your bill as well. Madam Chair, I want to thank you for holding this very important hearing on a good number of bipartisan public health priorities. I want to really thank you also for looking at the Protecting Access to Life-Saving Screening, the PALS Act, which is going to help millions of women between ages of 40 and 49 keep access to breast cancer screening. I also want to highlight Representative Wahlberg and Tonko's Lead Poisoning Act, which I've co-sponsored. We're certainly having a declared state of emergency in my district in Benton Harbor, Michigan, due to the lead in the water, and this bill is going to help ensure that those situations don't happen in the future. And I know that there are several expiring authorizations from 21st Century Cures that we still need to look at that were not part of this hearing, going along with Mr. Butterfield's comments, especially with regards to mental health. So it's my hope that we can add that to the workload list for reauthorization soon. Two questions in my remaining time. Ms. Stewart, as I mentioned before, we're currently facing a crisis in my home district in Benton Harbor related to lead in the water, and I was able to get $5.6 million in EPA funding last October for the city to replace lead service lines, and the state is providing additional resources that they've referenced just in the last couple weeks. What are some things that the federal government can do in addition to ensuring continued predictable support that H.R. 5552 provides for lead poisoning prevention and screening to ensure that this doesn't happen in communities? How can agencies at the federal, state, and local levels work better in order to prevent future crises? Ms. Stewart.
Thank you, Mr. Congressman, and I acknowledge that you've in Benton Harbor been experiencing and seen it up close and personal the devastation that has been created in Benton Harbor. I had a chance to visit Benton Harbor when I was a student at University of Michigan. Benton Harbor is a predominantly black city, and we know that lead poisoning does impact disproportionately people of color, especially black children and black families. And what's going on in Benton Harbor is simply a disaster, and it's a man-made disaster. And so, if we're prepared to deal with man-made disasters in other areas, we certainly should deal with it in this area, because lead poisoning has such a devastating effect on the health of families, on the health of children. One of the things that the Lead Poisoning Prevention Act does do is it reconstitutes this advisory committee at the CDC that for years supported CDC's childhood lead poisoning prevention program. It would allow there to be expansion of resources for grants, for support, for relief and recovery, especially in at-risk communities. We think that for a lot of states that are struggling with some of these issues, and we think it goes beyond just Michigan and Benton Harbor, that states need more support and financial support in dealing with these kinds of crises. And it's not only in terms of prevention, but it's also in dealing with the effects of lead poisoning as they exist today. So there have to be more resources paid to the attention to make sure that we can address those children, especially that have been impacted by lead poisoning. But again, to your point, also preventing it and putting more resources into the issue in places like Benton Harbor and more.
Yeah, we had some promising news just yesterday. The governor was there, Lieutenant Governor was there last week, and they've announced that they're going to replace all of the lines, hopefully within 18 months. And I know in what we call the BIF, the Bipartisan Infrastructure Bill that did pass the Senate 69-30 back in August, it includes $15 billion 4 lead lines in that as well. Dr. Dubois, can you speak to how the U.S. Preventative Services Task Force screening guidelines are tied to insurance coverage and copays? Isn't it true that any screening decisions, breast cancer, long run, any other preventive screening decisions that don't receive that A or B grade is no longer guaranteed coverage with a copay?
Can you hear me?
I can.
Yeah, that is correct. If it's not an A or B by the task force, then it is not automatically covered by insurance coverage. Although many societies and other bodies do recommend screening starting at age 40, and so that there's a lot of that going on. And I think this bill actually helps support funding for those services. Most people in the cancer field and other individuals in this area definitely feel that screening needs to begin at 40 for women for breast cancer.
Thank you. I yield back. Thank you, Madam Chair.
Gentleman yields back. Pleased to recognize the gentlewoman from California, Ms. Matsui, for your 5 minutes of questions.
Thank you very much, Madam Chair, for the recognition. And I want to thank all the witnesses for joining us today. You have been absolutely outstanding, and I really especially want to say thank you to my former colleague, Rick Nolan, for sharing your story. It's what a wonderful way to really honor Katherine in the sense that you are doing her work as far as trying to ensure that no one else goes through what she has gone through. So thank you, Rick. I want to talk about the early hearing detection and intervention, the EDDI program, which is proven key to improving public health for children and families. Before the program began 2 decades ago, less than 10% of infants were screened for hearing loss. And today, thanks to successful EDDI programs, the screening rate is 98%. But I am really concerned that all infants with hearing loss are not receiving the necessary follow-up treatment they need in a timely manner. So further, too many of our children who have been identified as deaf or hard of hearing are still facing disparities in access to care. Early childhood is, as we know, a crucial period for language acquisition, and it is critical that we equip healthcare providers and parents with the knowledge and tools they need to make timely decisions about hearing services and supports for their children. Now, with these goals in mind, I recently joined Ranking Member Guthrie in introducing legislation that will reauthorize this program. And I'm looking forward to our continued efforts here and have several questions about the status of the program. Ms. Stewart, it is important for the CDC to improve their hearing loss surveillance, research, and connection follow-up services. Could you explain what role CDC plays in ensuring newborns screened through this program can access the follow-up services that they need?
Well, thank you, Congresswoman. As we talked about, one of the things that's really important in all of this hearing is understanding the importance of early detection, of good data collection, and that extends to a lot of issues, including the issues around early hearing and detection. And we are doing a much better job, as we've talked about. When we look back in 1999, according to NIH, when prior to the establishment of this federal universal newborn infant hearing screening program, we were only screening less than 10% of newborns. We're now screening 98% of newborns. But what we also know, according to the CDC, in the school year, and these are older numbers, but from the school year of 99 to 2000, the total cost of special education programs for children who were deaf or hard of hearing was about $652 million. That's about $11,000 per child, but the lifetime educational cost for a child who's deaf or hard of hearing is estimated at $115,000 per child. So the costs that go into monitoring kids early in life isn't just screening them in the first month of life, which is what the recommendation is, that babies should be screened at 1 month. It's also making sure that there's funding and we're tracking the progress of children over their lifetime education, for their lifetime educational needs. And we would hope that the CDC would play a vital role in making sure that we can track that, as long as with what other lifelong health challenges or other issues that children may experience.
Ms. Stewart, would you agree that the increase in CDD funding in this bill is key to expanding these activities?
I would agree with that for sure.
Okay, Thank you very much. I was deeply disturbed as others about the Facebook testimony by the whistleblower, Frances Hogan, and about young users in particular who leading young users to anorexia content. I've long been concerned about the mental health impact of eating disorders on young people, especially young girls. In 2015, as the ENC lead of the Anna Weston Act, I was proud to support passage of this important legislation, which increased education and resources for those suffering with eating disorders. Now, while we've made progress in ensuring access to treatment, we have to do more to protect our kids from being exposed to toxic content on social media. Dr. Radesky, thank you for your testimony. Would you agree that the connection between mental health, eating disorders, and the algorithms that determine children's recommendation feeds is an issue area in urgent need of the funding and research provided by the CAMRA Act?
Yeah, thank you for that question. One thing I really appreciate about the CAMRA Act is that it tries to understand individual children's vulnerabilities to what might make them profiled in a certain way and therefore be fed content that's not in their best interest, how they might be profiled to send them advertising that is, also could nudge their behavior in one way or another that's not in their best interest.
Right.
One thing about eating disorders in particular is that we do need more research that focus on specific diagnosis populations, eating disorders or autism spectrum disorder or learning disabilities, ADHD. All of this would be much more robustly funded through the CAMRA Act.
Okay, well, thank you very much, Dr. Radesky, and I yield back.
Gentlewoman yields back. Pleasure to recognize the gentleman from Virginia, my friend, Mr. Griffith, for your 5 minutes of questions.
Thank you very much, Madam Chair. I do appreciate it. I'm going to go a little off subject because we have the stillbirth bill, which I think is a good bill. A lot of these bills are. But it came to my attention a couple of years ago, as often happens with us in our profession. I was at a county fair and a lady brought a situation to me that I think we need to work on. It's not our committee, so we can't do anything about it, but it deals with stillbirth situations. And many states, including Virginia, in fact, there was a somewhat notorious prosecution of a lady who had a stillbirth, and Virginia law, because she just put the baby in the trash can. But it was clearly stillbirth, no misconduct on her part other than that. And the state requires that you both fill out the proper forms, but that you also, once a baby gets to a certain age, we require a burial or proper disposal of the remains, which I think is appropriate. But we as a Congress have not done anything to give a tax credit. If the child is born alive and takes one breath, you get a tax deduction. You have all the same expenses. And in fact, what was brought to me at the county fair was a young lady who didn't know her baby had died and went in on the due date only to discover that the baby had died. And they had to put her through labor in order to take care of it. So she went through all the expenses, all the trauma of having a baby, knowing that the baby was dead, and yet no help from our federal government. So that's just an aside, and I apologize to our witnesses. I think it's important. I'm going to take another aside and go to you, Congressman Nolan, and I want Dr. Lloyd Jones to listen as well. I'm for the bill, so that's not the issue. But I'm wondering, because I had a constituent who his watch told him, "You're an AFib," and he went to have it checked out. They couldn't find it at first. He did a stress test, and sure enough, they found a heart valve problem. He had it fixed. It was no problem as long as he got it fixed, and he's out there doing fine today. I'm wondering if both in regard to lung cancer and you can't get your breath, is there some kind of, do we see any kind of future technology that would make it so you can basically do something at home? Your watch isn't going to tell you you're having a breathing problem, I don't think. But I'm just wondering if you know of any new technologies coming along. I'm for the screenings. I think that makes sense. But I'm just wondering if there's any other technologies that you're aware of that you might be able to do something at home to get an earlier screening as well.
Thank you, Congressman. That's a very good question. I think it's reasonable to understand why that early free screening wasn't initially given to the victims of lung cancer who were non-smokers, of whom there are many, because all that was available was a chest X-ray, and that was not very good. And it caused too many false positives and false negatives. But over the years since that time, low-dose CT scans have been developed that are very, very good, and as good or equal to the screening techniques made available for other cancers. So I think it's the advance of technology that makes this legislation ready.
And that makes sense. And I will tell you, because of stuff I had going on as a kid, they spotted a little teeny spot on my lungs and popped me into one of those, and everything's fine, and it's not a problem. It's just old scarring. But that's what they were looking for. But you shouldn't have to have a spot caused by having bronchitis 100 times when you were a kid that gets you that screening. And I think that your legislation is
well, thank you.
Right on.
And I might tell you, my daughter was a very physically active and very conscious of her health. And she had started a new business and had kind of backed off a little bit on her daily exercise routines and figured that her lack of breath was because she hadn't been exercising as properly as she should have. And so she doubled down on her exercise, and things didn't get better, they got worse. So she went to the doctor and was diagnosed. And by that time, it was too late. It was terminal. But I might add to the committee, and thank you, because this committee's played such an important role in the advances in preventing and extending the lives of cancer victims. And, you know, Catherine, I started to say my aunt Eleanor Nolan was dead in 6 months after.
Right.
Catherine lived another 6 years.
Yeah.
And had great time with her family and her husband, and was able to devote much time to advocating for lung cancer victims, donated her body to the Mayo Clinic, and was very grateful for the men and women who have promoted good public policies. And I would be remiss if I didn't thank the committee for the work that's been done over the years.
Well, I thank you for that. And Chairwoman and I were talking about it earlier, and that so much of what we do here is not partisan. It's just trying to solve problems, and that's what this committee normally tries to do. My time is up. I may ask a few questions after the fact of Dr. Lloyd Jones. I will note, as the head of the Welsh caucus, Dr. Lloyd Jones, that as a fellow with the name of Morgan Griffith, it's mighty nice to have somebody who's got at least some Welsh ancestry, because you wouldn't have names of Lloyd and Jones if you didn't have some Welsh ancestry. So I look forward to your answers to the written questions I'll submit later. I yield back.
Gentleman yields back, and he says that with enormous pride. And we're proud of you, too. So the chair now recognizes the gentleman from Maryland, Mr. Sarbanes, for your 5 minutes of questions.
Thanks very much, Madam Chair. I want to thank our panel for their testimony. I want to thank in particular our former colleague, Rick Nolan, for being here and delivering very difficult but powerful testimony. All the bills that we are hearing about today are very critical. I'm going to focus on one that's already gotten a fair amount of attention that I, along with many of our colleagues, are co-sponsors of, which is the CAMRA Act. We certainly know that the internet and the digital revolution have been vital tools, have created vital tools for innovation, creativity, economic growth, both for individuals and communities, obviously. But we also know that it's created a lot of new considerations around safety and health that we have to address. I'm often discussing the use of media, particularly social media, in the context of protecting our democracy and safeguarding our elections and things of that nature. But I'm also super concerned about the effect social media is having on our children's well-being. And we know the topic's getting a lot of attention increasingly now, which is good. But it means we really have to wrestle with what are the solutions? What do we bring to bear to make sure children are protected? Dr. Radesky, you've already talked at some length about all of this. I wonder if you could speak for a moment to whether there's a way, whether we should have the ambition, I guess, of trying to kind of flip the presumptions here, that when these tools are being developed inside of these large digital ad companies, or frankly, inside any organization that's going to deploy them widely, whether they should, in a sense, have to first demonstrate the precautions they're taking to protect children before the tools are more widely deployed. Because as you know, and I think you've testified, you know, there's a blind spot there. These get developed with adults in mind and how to sort of cultivate the connection with adults. But the collateral damage on young people is huge. And I'm sure you've been tracking with your own work whether you're beginning to see any culture change inside some of these organizations where they front load their focus on what this can do when it gets in the hands of children, knowing that that's going to happen. And then in a sense, back out the product line from there instead of it being an afterthought. So if you could speak to that for a couple of minutes, I'd be interested to hear, because I think that could guide the way we design legislation here on the Hill to try to protect young people in this digital age with all its benefits, but as we know, with some severe drawbacks as well.
Thank you. That's an excellent question. And I really like the emphasis on children not being an afterthought. Children have such different ways of interacting with digital spaces that it's normal that adult designers wouldn't recognize all those things. But we have lots of know-how from really good research on TV and video games about how children experience those platforms. What we need is more research to inform our advisement to tech companies about how a child at different developmental stages, from infancy to preschool, elementary school, teenage years, would interact with different types of algorithms that elevate different content, that might take off different social engagement metrics like liking and sharing. And one thing that I've been impressed with from a policy standpoint is the UK and the EU have done a lot of movement in the past few years about a child-centered design code. And here in the US, I sit on a steering committee along with other folks like Center for Humane Technology, Common Sense Media, Fair Play, where we are trying to find the same sort of child-centered principles to put children's needs first before products are released. In the EU, they're recommending or debating a child impact assessment before tech is released so that you can have child experts and technologists working together to say, can we anticipate how this might be misused? Can we do some trial runs to see what are the metrics that show children are really benefiting from this? It's giving them new ideas, not sucking away their time.
Thanks. That's really helpful. That's exactly the answer I was looking for. And I like this concept of a child-centered design code and sort of making sure before the broader rollout happens that assessment's being done. And we can learn from what our peer nations are doing around the world, absolutely, in this space. Thank you very much, Madam Chair. I yield back.
Thank you, Mr. Sarbanes. The chair is now pleased to recognize the gentleman from Florida, Mr. Bilirakis, for your 5 minutes of questions.
Thank you, Madam Chair. I appreciate it very much. And I feel blessed to, of course, represent the 12th Congressional District in the state of Florida, but also to sit on this committee and make a real difference, because this is the best committee in Congress, without question. Thank you, Madam Chair.
Thank you.
Again, I was particularly glad to see the bill I co-lead with my friend, Representative Cardenas, the Oral Health Literacy and Awareness Act, included on today's docket. So thank you again for that, Madam Chair, and the ranking member as well. This bipartisan bill would direct HRSA to develop and test oral health literacy strategies capable of reaching across vulnerable populations to provide oral disease prevention education through a 5-year oral health literacy campaign. Dr. Cassis, Can you tell us why HRSA is best equipped to push out such a campaign as opposed to an entity like the CDC? And can you explain why establishing evidence-based strategies as outlined in this bill are important to ensure the agency is reaching our communities effectively?
Certainly, I would be happy to respond to that. And forgive me, I'm from West Virginia, and we don't talk real fast here, unlike some of my distinguished colleagues on the committee and witnesses. But to be quite factual, RISA is a much smaller organization than the CDC, and they definitely deal with a lot of facts as opposed to how you guys operate in knowing, is it a good program or not? They can with their small size, we can figure it out real fast whether it's effective or not. And as far as the funding for that, it's really a small amount, but it is the catalyst that may help. Again, I've been in practice 42 years, and I have to speak so many different languages of understanding with all of my patients. So if there's better ways to get people into the office, then we need that common thread of what works for everybody.
Thank you, sir. Next question is for Ms. Miller. I want to thank you for testifying today and highlighting the importance of the Gabriella Miller Kids First Research Act 2.0. I appreciate everything, which I'm proud to be a co-sponsor, the Republican lead. I'm glad to see many other members joining in support of this, of course, very important legislation named after your late daughter. May her memory be eternal, and remain hopeful we can continue to move this forward through the legislative process. We know that all pediatric cancers are considered rare, but that's not a rare problem, as you know. And as co-chair of the Rare Disease Caucus, we need to ensure we are directing much-needed research funding and attention for these most vulnerable patients. Some have expressed concern that using civil fines to fund the pediatric research initiative could result in varying levels of money each year. Can you elaborate why you believe using this particular mechanism can be helpful in properly funding these critical programs? Because obviously you have a lot of support for the program. If you could answer that, I think that would be very helpful.
Well, first, let me thank you for being an original sponsor on this piece of legislation. I appreciate your leadership on this. As you stated, the funding for childhood cancer and childhood disease is desperately needing an infusion. The childhood cancer gets approximately 4% of the NCI budget. And what's so fantastic about this piece of legislation is the unique funding source does not require our elected officials to appropriate the other 96%. It could stay as is. It supplements what we already have. And what's also fantastic about it is that it will be a never-ending source until such time as we have no longer a need for that. And right now, there's such a desperate need. So this source of funding is unique and innovative and will truly move the bar forward. Thank you for asking.
All right, very good. Sounds great. I'll yield back, Madam Chair. Thank you.
Thank the gentleman. The chair now is happy to recognize the gentleman from Vermont, Mr. Welch, for his 5 minutes of questions.
Thank you very much.
There you are.
It's always good to see Mr. Nolan. I mean, most of the time. And it's always good to see Ms. Miller. Such fond memories of us working together with Eric Cantor to pass the first bill. But I do want to say sincerely to both of you, it's so refreshing in this world that's so filled with strife, and then oftentimes with personal pain and personal loss, to have before us two people who've turned that loss, that pain into progress, in benefit for other people. That's inspiring for all of us. So, Rick, I want to thank you, and Gabrielle, I want to thank you so much on behalf of your daughter, Gabriella. And I see your husband's here too, and I have fond memories of the bill signing. We went down with Eric Cantor, and President Obama signed it, and even as that was being signed, you were advocating with President Obama for the next step. So thank you very much. Ms. Miller, Marilyn, I want to ask you about the funding source, because that was the whole issue here. And how is it that, just elaborate a little bit about what the insecurity is of the funding source and why it is that we need to have this Gabriella Biller 2.0. Thanks, Marilyn. Go ahead.
Again, as with Congressman Bilirakis, let me thank you for your support. And you are an original sponsor of the first piece of legislation. And when I approached you on this one, you just immediately said, count me in. So thank you for that. The original piece of legislation was a dedicated funding amount. We knew that every year that we get it appropriated, it's $12.6 million. This new funding source, we don't have that. We need to wait, obviously, for a penalty to be found. But and Madam Chair asked earlier the amounts of the monies, and I wish that I could answer that with a definite answer, but we don't know how much they could be. It could be,
My staff tells
$10 million.
me that that the total amount of, in terms of penalties that came in that go into the general fund in 2019 was $335.8 million. So I'm surprised some member hasn't found that money before to use for filling
It's
the
ours.
blank.
It's
But
ours.
It's a good sum
Yeah,
of
but
money.
the bottom line here is there's got to be some stability in the funding if we're going to do the research.
So one thing that we
Right.
truly like about this piece of legislation is that, we don't know that we'll get a penalty every year. So there could be a year that there is no funding. And what we've done differently in this year is once our bill was introduced in the 116th Congress, I reached out to Dr. Collins, the director of NIH, and I asked him to help me with language so that we could ensure that it's not a use it or lose it situation as it was with the original. Right. And his staff helped, and we got that language put into our current legislation where it will allow for it to roll over. So there will never be a year that will go by that there won't be any monies that are allowed for continued research.
Thank you very much. And I want to ask Congressman Nolan, if you were back here, what would you have Congress be doing to assist cancer patients from diagnosis, throughout diagnosis and treatment?
For lung cancer, I presume.
Yeah, that's right.
Well, I'd like to see it become a national priority because it's a national emergency. Every day, 361,000 people die. It's like an Airbus going down every day and every passenger being killed. Okay. And I think, there's some very disparate treatment between lung cancer and the many other cancers. Lung cancer kills more than almost all of them combined. It's been stigmatized because of smoking.
Right.
And while other cancers are given early detection as a common procedure, lung cancer victims only get it if they're 55 years of age and have smoked 20, 30 packs of cigarettes a day for 20 or 30 years.
Right.
And it's become epidemic among young women between 20 and 30. And so providing early screening,
right,
as well as additional funding for research and prevention, and those, I think, is the most important thing I think we can do. It will save tens, if not hundreds of thousands of lives by providing that early screening and detection for lung cancer.
Thank you very much, and thank you again both for your advocacy.
Thank you.
Gentleman yields back. Pleasure to recognize Dr. Dunn of Florida for his 5 minutes of questions.
Thank you very much, Madam Chair, and Ranking Member Guthrie for hosting this hearing today to consider legislation related to public health. On public health focus over the last 18 months has appropriately been on COVID-19, and we've experienced successes and failures with COVID-19 and should legislate accordingly. We also, however, now have to ensure that Americans are able to get back on track when it comes to maintaining their health and staying up to date with routine healthcare visits. I'm very concerned that the data indicates nearly 10 million screenings for cancer were foregone during the public health emergency so far, which is why I introduced H.R. 5558, the Prostate Cancer Prevention Act. This bill will reauthorize the expired CDC prostate cancer research prevention program. And I want to thank my colleague, Mr. Bobby Rush, who's chair of the Energy Subcommittee, for co-sponsoring this important bill. I witnessed firsthand immense progress in the field of cancer treatment throughout my medical career and continue to be amazed at how far we've come. I'm concerned over the impact of COVID-19, what it has had on the diagnosis, treatment, and outcomes of cancer. An essential aspect of success in the field of cancer is, of course, early and accurate detection of disease. Dr. Dubois, I have a question for you. You spoke during your testimony about the importance of cancer screening. I appreciate your comments regarding evaluating the whole picture of an individual's risk when considering cancer screening, and I believe that a strong doctor-patient relationship leads to this type of thoughtful risk assessment. Doctors should be looking at far more than just age and race when making determinations about risk. And physicians should be examining the full spectrum of risk, including life circumstances and whatnot, when making screening recommendations. We should be empowered to make the most appropriate care recommendations for each of our patients. So, Dr. Dubois, could you elaborate on your concerns regarding the Preventive Services Task Force reform and how to ensure that the task force is not impeding appropriate patient care decisions?
Well, thank you for the question. I think the task force has sometimes a difficult task because they really are focused on looking at the whole population.
We need you to speak up. We need you to speak, get closer to your microphone, maybe raise your voice a little bit. We don't want to miss what you're saying.
Thank you.
Okay, so can you hear me now?
Yeah, it's better.
Okay, sorry about that. The task force looks at the whole population and they calculate their risk and benefits of that screening and who would benefit most and who would be harmed by it. It's really made up of individuals who are mostly public health experts or epidemiology experts and people like that. And it's, it's a sort of a formula that's examined. I think you're right in the sense that there are many other exposures and issues related to the hereditary issues. There's environmental exposures. There's secondhand smoke exposures, and a lot of those aren't considered in the calculation. So it's always important for patients to speak with their primary doctor.
So our time grows short, Doctor, so I'm just going to jump in with another question to you, and I encourage you, as Chairwoman O'Shue did, to turn up your microphone a little bit because you are soft. So throughout the COVID-19 pandemic, the CDC has repeatedly released inconsistent guidance surrounding masking, testing, immunity, just simple knowledge about it, classroom policies, et cetera. Do you think that inconsistent messaging from public health agencies in general, but specifically regarding COVID-19, harms our federal public health efforts regarding cancer screenings and credibility moving forward?
Can you hear me better now?
A little. Go ahead.
Sorry about that. I'm not sure.
The clock's running. Go ahead and answer.
Well, the CDC, it's a tough situation. There's been a rapid development of agents for treating COVID patients and diagnosing them, and we've learned a lot in a very short time. So it's been a very difficult issue for the whole medical field to deal with. In terms of, for cancer patients, which is my main focus, We're trying to get everybody vaccinated. We're trying to make sure that they're as protected as possible because of their immune compromise from their treatment and from their disease.
Thank you. So I would just summarize it. I think that credibility in cancer treatment also suffers from credibility on general public health announcements, and I suspect that you would agree with that. With that, Madam Chair, thank you, and I yield back.
Thank you, Dr. Dunn. The chair is pleased to recognize the gentleman from California, special friend to me, Mr. Cardenas, for your 5 minutes of questions.
Thank you very much, Madam Chairwoman, and also Ranking Member Guthrie for having this very, very important hearing. And I want to thank all of my colleagues for the diligent effort that we have had in this discussion today and the work that we've done leading to this day and the work that we have yet to do to complete, to do the work that is demanded of us. I say that respectfully, demanded of us, and I want to give a special thank you to somebody that I love very dearly, my former colleague, Congressman Rick Nolan. It's just so wonderful to see you. You are one of the kindest individuals to ever serve in this House, and I miss you very much. And we are going to do everything that we can to keep your promise to your daughter and to all the people who deserve the best of us, the best of us. And we must keep in mind that what we do on this legislation, these pieces of legislation, not only will honor those who have passed, but it will more importantly honor those that will live, because we have given them the opportunity to have the respect and the dignity that they deserve, so that if in fact cancer comes their way, that they will survive, because we are and shall be the greatest nation in the world, not by our military might, but by the care that we give to every human being that deserves the best of us, the best of us. I would like to start by thanking my colleague, Rep. Bilirakis, Republican, by the way, and I'm a Democrat, and together we introduced a bill, which is H.R. 455, and that bill actually is included, and I want to thank the chairwoman, the ranking member for doing so, and it is the Oral Health Literacy Act. Yes, oral health, something that's very important, something that has already been explained today that most Americans don't have access to or don't afford themselves the opportunity to get that dental checkup, to be preventative about saving, yes, in some cases actually saving their life by making sure that they get preventative care. This bipartisan bill will allow U.S. Health Resources and Services Administration, otherwise known as HRSA, to carry out a public education campaign to increase oral health literacy and awareness. Chairwoman Nestor, I'd like to request that we enter into the record at the end of this committee hearing a letter of support for this bill, H.R. 455, by the oral health professionals and stakeholders.
So ordered.
Thank you, Madam Chair. I'm grateful again for the inclusion of this bill in this important hearing, and I hope to see it advance for the sake of all of us in this great country. Dr. Cassis, thank you again for being here, and I would like to ask you a question. Is there, when it comes to people in America not having true access to oral health care, is it only people who, for example, are homeless, or is this include people who are working perhaps 1, 2, 3 jobs? Are people who are hardworking Americans, are they not having access to oral health?
Thank you for the question, Representative Cardenas. It is across the board. It has nothing to do with, where you might live. It is definitely across the board. We have to do a better job of communicating the necessary appointments to safeguard their lives. As you said, there are people that die from dental disease and complications every day.
So Dr. Cassis, again, could you please help emphasize we're talking about many of these individuals are hardworking full-time workers, people who are working full-time, and they and their family members don't have true access to oral health care. Is that the case in America today?
It is. You're exactly right. They have to ration their dental care out just like they have to ration food at times. And it's not a pretty scene, but it is across the board.
Yes, thank you. I wanted to emphasize that because I think in these hearings, when we talk about helping those who are less fortunate, a lot of people think that we're not talking about you, hardworking Americans. We are definitely talking about you, people who are holding down a full-time job, single moms. We are talking about you. That's who we're fighting for. And I see that my time has expired. Thank you very much, Madam Chairwoman. I yield back.
Gentleman yields back. Pleasure to recognize one of the outstanding doctors that is a member of our subcommittee, Dr. Bucshon of Indiana. You're recognized for 5 minutes. Good to
Thank
see
you, Madam Chairwoman. And I'm sorry for not being here for a good part of the hearing, but I've read your testimony.
Oh, Dr. Bucshon, can I just interrupt for a moment? And I'm not going to, I'm not taking your time away. I've been asked to remind members and witnesses that are not in the hearing room to turn off your mics, mute them, because there's background noise on the live stream. We're not picking it up here, but evidently others are. Okay? Thank you very much. And Dr. Bucshon, you're recognized for 5 minutes.
Thank you, Madam Chairwoman. Mr. Dubois, is it Dubois or Dubois? I want to thank you for focusing in on the importance of preventive health and routine screenings, especially for cancer. As a doctor myself, I believe Congress can do better in promoting preventative health. I also agree we need to encourage Americans to screen early and screen often for preventable diseases, especially now that so many are behind in their screenings due to the public health emergency. A growing concern I have regarding routine screenings is our ability to maintain timely access to quality cancer care in all settings. While many facilities are already facing physician shortages across the country, many are also facing the reality of having to scale back staff or even worse, close due to looming reimbursement cuts that they are facing at the start of next year. Coupling the fee schedule cuts with the proposed update to the clinical labor component, some providers I talk to are facing up to 20% in cuts. This is especially true for radiation oncology. Mr. Dubois, what are the real-world implications of proposed policies like these, and do you think such drastic reimbursement cuts would disrupt access to quality cancer care?
Can you hear me okay now?
Yes.
Okay. I had to switch my microphone. I'm sorry about that earlier. Well, those cuts are having impacts, and I know exactly what you're talking about. My focus on my testimony today was really on cancer prevention, but those changes in reimbursements for the radiation oncology and other services, will have an adverse impact. I don't know the total extent of that, but clearly we need to keep an eye on that and make sure that, we can continue to support those individuals who are providing that essential care.
Thank you very much. And earlier this Congress, I joined my friend and colleague, Congressman Rush, in introducing the PSA Screening for Him Act. This bill waives deductibles, co-payments, and co-insurance for prostate cancer screenings for African-American men and men who have a family history of prostate cancer, as both of these patient populations have a much higher risk of prostate cancer. By encouraging early and routine screening, doctors will be able to catch the disease in its early and treatable stage, saving countless lives. Congress, I think, has a bad habit of looking at healthcare policies in a 10-year budget window, ignoring potential savings that accrue past the 10-year mark. So frequently that blocks healthcare policy because it costs money in the short run, but in the long run, I would argue, saves not only lives, but money. Although many preventive care policies seem to cost some on the front end, I think it's prudent for us, for the reasons I've explained, to look at these policies as they affect the entire lifespan of individuals. Mr. Dubois, how do screenings for for early detection and preventive health measures lead not only to lives saved, but also lower costs to the overall healthcare system? And how can we do better as a country in promoting and encouraging preventive health?
Well, thank you for that great question. I've devoted my entire sort of career to cancer prevention and early detection. And the data is coming out now. Some very good studies have been done in colon and breast and other cancers. Clearly, when we can detect it early in the precancer stage or early while it still hasn't metastasized, the outcome is just tremendous. There's a much more longer term of life. There's if it can be removed early by surgery, there's a cure, a chance for a cure. So early detection definitely pays off. The health economic studies have been done, and the overall long-term impact is tremendous. So I agree with your statement. I think we need to focus more on disease prevention. It's something that we do in cardiovascular disease and other diseases, and cancer is something we just can't ignore.
Do you think there's things, I mean, obviously, paying for preventative or early detection things like that we've started to do a number of years ago for example, breast cancer screening and screening colonoscopy, for example. I mean, are there things we can still do better? Is it primarily just reimbursement, or are there other things the federal government can do more to encourage people to take advantage of preventive evaluations?
Well, I mentioned this in my testimony. There's definitely some underserved rural communities who don't have good health coverage and don't have access to this type of screening. And the outcomes are much worse in those populations. It's very clear. One thing that we've been doing here is sending out screening mobile units to these areas so that we can include those populations in that type of early screening. There's some very exciting research that's supported by the NCI that's developed a blood test for pan-cancer testing. Cancer cells are released into the bloodstream, and this test can detect when they're present and what tissue they came from. It's too early to deploy this clinically, but once those tests are validated and sensitive and specific enough, it could really change the way we do our early screening for all cancer patients.
Thank you, Madam Chairwoman. I yield back.
Gentleman yields back. The chair is pleased to recognize the gentlewoman from New Hampshire, Ms. Kuster, to be followed by the gentleman from Missouri, Mr. Long. Annie, you're on.
Thank you so much, Madam Chair. This is a very important discussion, and I want to thank the witnesses, especially my very, very dear friend and colleague Rick Nolan, for joining us here today. While this committee has been keenly focused on the COVID-19 pandemic, we must continue to support and invest in programs that protect our children and families. We've all heard the startling statistics of delays in routine health care during COVID, and there are simply too many Americans, including, I might add, my own brother, who recently postponed screenings and surgeries, only to later discover they may have much more serious healthcare conditions. We've also discussed in the Oversight and Investigation Subcommittee the enormous impact the pandemic is having on our children, and I recently raised the issue of adolescent mental health during a visit to Mountain Valley Treatment Center in my district in Plainfield, New Hampshire. It was incredible to hear directly from these teens about the mental health challenges that they're facing. And I'm pleased that today's hearing includes the CAMRA Act, which would have the National Institutes of Health research the effects of technology and media on infants, children, and adolescent health and development. We need to better understand the effects of digital media on our children's well-being, and I'm a proud co-sponsor of this legislation, as well as the Carroll Act, which would expand research on valvular heart disease and treatment. Many Americans, particularly women, suffer from valvular heart disease, and they do not know that they are at serious risk. So we need better public health outreach and data to address the gaps in understanding, especially for women, people of color, and those living in rural areas like my district. Dr. Jones, could you elaborate on how valvular heart disease and its related complications despite requiring minimal intervention, can become fatal.
Certainly. Thank you so much, Congresswoman. So we're talking today really about chronic valvular heart diseases, and they come in two subtypes. There's either narrowing or scarring of a valve we call stenosis, or there's leakiness of a valve we call regurgitation. But really, at the end of the day, both of these lead to a kind of a final common pathway where the heart tends to enlarge, the pump weakens, and that leads to the development of heart failure symptoms, congestion, development of shortness of breath, retention of fluid. And when severe enough, that leads to rhythm disturbances that can cause sudden cardiac death. So because of these processes, it's incredibly important, just as with cancer, that we catch these processes early. And that really requires routine screening, again, with the stethoscope, but also if there's any suspicion of a valvular heart problem, that we do echocardiography or ultrasound to be able to detect both the presence and the severity of valvular heart disease.
And what role do health disparities due to gender, race, or socioeconomic status play in increasing the risk for fatal heart valvular disease?
Well, there are really no known major genetic or sociocultural differences that sort of lead to disparities. So I'll come back to the issues really of access to healthcare. It's really that access problem that means people are getting diagnosed only when they have symptoms after the heart has been damaged too significantly to actually be able to reverse that damage and avoid some of the complications and potentially deaths that are related to it. So much of what drives those disparities is the underlying risk factors for heart disease: high blood pressure, diabetes, cholesterol problems, and smoking. So if we can address those things, those upstream determinants, it will also help with valvular heart disease as well. But of course, there are major health disparities in all of those things as well.
And is there a factor related to gender? I know that women seem to be particularly at risk.
Yes, there are some issues with gender related to valvular heart disease and also in some of the consequences like sudden cardiac death, where women may be more susceptible. So, I think that encouraging women to get this as part of their routine screening, make sure that someone is paying attention to their heart and their heart valve is incredibly important. We know that only recently, fewer women now are dying of heart disease than men, but still far too many, and over 400,000 women per year dying of heart disease. Much of that, 80 to 90%, would be preventable with good routine screening and care.
So I'll just close by saying that's why it's so important for us to provide access to affordable health care to every American, including those in states like Florida and Texas, large states with large populations that did not increase their roles under the Medicaid expansion. And that's why we want to include that in the Build Back Better. So I thank you and I yield back.
The gentlewoman, let's see. Oh, the chair is pleased to recognize the very patient, wonderful member from Missouri, Mr. Long, for your 5 minutes of questions.
Thank you, Madam Chair. And Rick, I'd like to start with you. Are you familiar with Philip Francis Thomas?
With who?
Philip Francis Thomas.
No, I'm not.
Philip Francis Thomas was a congressman in Washington, D.C., and he had a small gap in his service of 34 years, from 1841 to 1875. 34 years. So he's number one. Who would you think number two is that had a 32-year gap in their service in Congress?
Yes, mine was 32 years.
Huh?
My gap was.
Can you take your
32
mask
years.
off so I can see what you're saying?
I guess I'm number two, huh?
Yeah, but I just wanted to point that out to the folks that are seeing this, that you were in Congress and then had a little minor 32-year gap and came back to Congress same year that I came in, and it's very good to see you again.
Oh, thank you. I enjoyed serving with you. It was a great.
And this is a very important hearing that we're having here today, in particular near and dear to my heart. Our youngest daughter was diagnosed with Hodgkin's lymphoma 6.5, 7 years ago. We thought we were going to lose her, knew nothing about the disease, and I couldn't talk to anybody. I couldn't pick up the phone. I couldn't talk to friend or foe for a couple of weeks when she was first diagnosed. And I'm proud to report that she's 6 years past her last chemo treatment, actually got married last October. And and then our older daughter is a pediatrician. So she deals with a lot of these situations, especially on the children and things. And I'm also a member of the Black Maternal Mortality Caucus. We had one of the most heart-wrenching testimonies ever delivered in this hearing room a couple of years ago by a fellow that lost his wife during a pre-planned C-section. And she was having issues, and they actually came in and told her that she was not a priority, and he was begging for her life for a 16, 18-hour period, and she deceased with her second child, like I said, in a planned C-section. So I know what the mortality rates like with black women, and it's not acceptable, and I hope to be able to do something. I've been on that caucus for a couple of years now. Dr. Lloyd Jones, there's really an untold story about how COVID took a toll on people, and it's not always reflected in the numbers. COVID and shutdowns disrupted normal health care for months, and many people were simply not able to receive normal treatments. If it was a non-critical treatment or if it was a routine procedure, the hospitals were not allowed to do it. And sadly, that adversely affected Andy Barr's family, his wife Carol, who we've been talking about here today. I was on the House floor one day, and Andy came up to me and he had his cell phone out, and he said, "Read this, Billy, read this." And he had just received the notes from his wife's doctor. He came home 37 years old, I believe she was 37, 39, and was deceased after he came home from a meeting. And two beautiful young daughters that Andy's raising now. But he said, "Read this." And I read his cell phone, and it was the notes his doctor had written. And they said that echo after virus subsides. Well, the virus didn't subside, and Carol subsided before, so they couldn't do an echocardiogram because it was not considered a critical procedure that would have probably most likely have saved her life. And so I'm a proud co-sponsor of the Carol Act introduced by Andy Barr, my buddy from Kentucky. And Dr. Lloyd Jones, we still don't know a lot about heart valve disease causes and the factors that increase risk for sudden cardiac death. Obviously, that's the reason why this bill is so important. Can you talk about the workshop that this bill creates, what its goals are, and how the findings of the workshop are translated to results at the National Institute of Health and the National Heart, Lung, and Blood Institute?
Thank you, Congressman, and thank you for sharing that story. I think it's tragic and really important that we get our patients back under care as quickly as possible. So the NIH uses workshops as very important fact-finding opportunities, and I've been a member of a number of these for the NHLBI, but it's really an opportunity to bring together experts in the field, researchers, even industry and other public-private partners to make sure we understand all aspects of a situation, and that then NHLBI can use, or NIH can use that information to actually design calls for research and grant applications so that we're really targeting the most important aspects of whatever the disease of interest is. In this case, you're absolutely right. We need to know much more about the causes, the reasons for progression, and the links to sudden cardiac death related to valvular heart disease.
Okay, thank you. And unfortunately, I'm out of time with all my gift of gab beforehand, so Madam Chair, I yield back.
And we enjoy all of it, Mr. Long. You add a great deal of interest to our committee. You really do. The chair is pleased to recognize the gentlewoman from Illinois, Ms. Kelly, for her 5 minutes of questions.
Thank you, Chairwoman Eshoo and Ranking Member Guthrie, for holding this important hearing. Today, we are focusing on legislation that impacts a wide range of diseases. While it's important to increase research funding for cancer and other diseases to identify new treatments, we also need to ensure that clinical trials are reflective of racial disparities in disease. According to the Prostate Cancer Foundation, Black men are 75% more likely to develop prostate cancer and more than twice as likely to die of it compared to other racial groups. Yet, according to the The median percentage of Black participants in prostate cancer clinical trials funded in FY 2018 was only 8%. Dr. Dubois, how can public research funders such as the NIH hold clinical trial sponsors accountable for increasing the diversity in clinical trials?
Thank you for that question. Can you hear me okay?
Yes.
Good. Well, this is a big problem. And one of the things the NIH has done through the NCI is to establish these community oncology outreach efforts where we have community oncology groups that actually do participate in clinical trials. We have 5 of these sites in South Carolina, and we found that if we have those trials available in the communities where most of these people live, there's a much higher likelihood that they're going to participate. And so we've been able to increase the percentage of minorities in many of the trials. And it's really in the outreach efforts that we're doing in those local communities. I think we really need to program because we're also missing out on other community groups where patients just can't get to major urban areas where a lot of those trials are being held. And so I think more support for this program would be wonderful and improve participation from those groups.
Thank you. Would there be any benefit to empowering NIH with greater authority to work with clinical trial sponsors to establish clear, measurable diversity goals in the funding application?
I think that's a great idea. And, they do look at that in some applications. It's not probably as stringent as it should be, but I think that that's something that could be beefed up.
Thank you. We do need to increase accountability to make sure that all clinical trials represent racial and ethnic disparities in diseases. This is why I'm working on a clinical trial diversity bill with my ENC colleagues, Representative Cardenas, Butterfield, and Clark. And we look forward to working with the committee to advance this important issue. Ms. Stewart, good to see you. In your statement, you mentioned the importance of increasing access to prenatal and postpartum care. Can you speak to the role that extending Medicaid postpartum coverage to 1 year can play in reducing racial disparities and maternal health outcomes?
Good to see you, Congresswoman. Yes, we've been a big advocate of extending Medicaid postpartum at least 12 months. We've made some progress towards that, where it's now an option for some states to do that, but we feel it shouldn't be an option, it should be mandatory. And the reason for that is because when you look at maternal deaths between pregnancy at the time of childbirth and then after childbirth, about 1/3 of all maternal deaths happen in that stage 1 week beyond when the baby is born out to 1 year. And that's when women need care just as much as they do when they're pregnant, just as much as they do when they're delivering their baby. We know that a lot of women are suffering with mental health challenges. They may have extenuating health challenges that may have developed during pregnancy or at the time of childbirth, and they need to be seen by a care provider. And because Medicaid covers 40% of all the births in the country, and because so many women of color are a part of that coverage, we know that it can go a long way to helping to eliminate and reduce the disparities that we see between Black maternal health, brown maternal health, and other groups as well.
Well, I'd like to thank you and commend the March of Dimes for your work to address maternal mortality. And you know that I'm out here fighting to do exactly what you said is needed. So thank you so much, and I yield back.
Gentlewoman yields back. Pleasure to recognize the gentleman from Oklahoma, Mr. Mullen, and then coming up, followed by Blunt Rochester from Delaware, followed by Mr. Carter from Georgia. I think that's the lineup. I know that we have votes scheduled, I think at about 1:45. So let's see if we can make it before the votes are called. Okay, so Mr. Mullen.
Thank you, Mr. Chairwoman. I appreciate it, and thank you for holding this hearing. Ms. Stewart, with the United States ranked 25th in the number of stillbirths per capita, why do you think these rates remain unchanged despite medical innovations? And what interventions do you think other countries have done that we aren't, that's lowered their stillbirth rates?
Thank you, Congressman. I think it's a very good question. I mean, yes, we've seen stillborn rates where today 24,000 babies die as a result of stillbirth. And that rate that number has not really improved. In fact, when you look at other countries, we are ranked 183rd out of 195 countries in terms of reduction of stillbirth rates over the last 2 decades. So we have a lot of work to do. When you look at other countries, they have implemented successfully, for example, in Australia, some impressive care bundles that look at issues around early detection of fetal growth restrictions, smoking cessation, which we actually do focus on a lot in this country, decreased fetal movement, safe sleeping practices for moms, some side sleeping practices, making sure that babies are avoiding early C-sections so that they are not born early. You know, one of the things that we have to do is just have a more comprehensive approach to maternal care. And I think a lot of the gaps in our system of care, again, these maternal care deserts that I talked about, the lack of access to care if you don't have insurance or if you just don't even live near a care provider, are all contributing to the high rates of stillbirth. And because we have not made comprehensive improvements in maternal care in this country is also why we have not seen much improvement in stillbirth, even though we've seen increases in NICU care, where we've seen technology and medical care actually extend life of babies in the NICU. We have not seen that same kind of advancement with stillbirth.
Thank you. How important is adequate data then to fight this, to fight against stillbirths?
Sorry, I just want to make sure how important is adequate.
Yeah, when you start looking at data, what do you feel about? I mean, there doesn't seem to be that good of information out there when we start talking about data, and so when we're looking at fighting the stillbirth, I'd almost say a pandemic, but it's not really. But you know, the serious issues we're dealing with there. When we're looking at it, how important is that data?
So it's really important. One of the things that we know when a stillbirth occurs is that it may be noted on the death certificate, but that doesn't explain the full reason or all of the underlying issues that may have led to the stillbirth. And in fact, some tests that would determine that actually are made available sometimes weeks after the death certificate is actually filed. And so we haven't been actually collecting all of the best data around stillbirth. And so what the Shine for Autumn Act will hopefully do is to provide more resources so that we can do a much better job of research and data collection to understand first the underlying causes of stillbirth, which we need to do more of that around preterm birth and miscarriage and all of that as well, but also better data collection around stillbirth so we can design better interventions. We saw this same kind of progress that we made with maternal mortality when Congress passed legislation that would allow for maternal mortality review committees. Collecting better data allowed us to identify better underlying causes of maternal death, leading to better interventions. The same needs to be true for stillbirth as well, and that's what we hope the Shine for Autumn Act will do.
Well, thank you. Thank you so much because you answered all my other questions while you were answering that question. I really appreciate it. In closing, I just want to second what Mr. Butterfield said earlier. He made a suggestion that we look at the Better Wound Care Act at home and maybe look at doing an upcoming hearing on this. Madam Chair, I would like to say I'd like to second that because it's an important policy that's good for our patients, and hopefully I look forward to advancing this through the committee. With that, I yield back.
Thank you, Mr. Mullen. So noted. Thank you. The chair now recognizes the gentleman from California, Dr. Ruiz, for his 5 minutes questions.
Thank you. Thank you very much. This is a very important hearing. The COVID-19 pandemic has illuminated health equity issues that we have long known to be the norm in the United States. One disease that continues to disproportionately impact minorities is cancer, with unacceptably high death rates and unequal late-stage diagnoses. New multi-cancer early detection tests in development have the potential to detect many cancers simultaneously, including cancers without screening tests today and those that disproportionately impact underserved populations. While access barriers to healthcare services, including prevention, have improved over time, there is still much work to do. Technologies like multi-cancer early detection tests could reduce late-stage diagnosis by catching cancers earlier and saving lives. That's why I've joined my colleague Congresswoman Soul to introduce H.R. 1946, the Medicare Multi-Cancer Early Detection Screening Coverage Act, which would provide a possible future pathway for Medicare coverage of these life-saving technologies. While this bill is not under consideration today, I urge the committee to consider advancing this bill supported by a consensus of cancer care stakeholders and over 90 bipartisan members. So now on to the legislation at hand. Oral health is physical health, but too often people neglect their oral health, whether that is because they don't have access to a provider, or because they can't afford to see a dentist, or because they don't realize how critical oral health is. That is why I really want to highlight the bill introduced by my colleagues, Mr. Cardenas and Bilirakis, the Oral Health Literacy and Awareness Act of 2021, which will increase public education for oral health literacy and awareness. We know that there are oral health disparities by race and by income. According to the CDC, for children aged 12 to 19, nearly 70% of Mexican American children have had cavities in their permanent teeth, compared with 54% of non-Hispanic white children. So for that same age group, 23% of children from lower income families have untreated cavities in their permanent teeth, twice that of children from higher income households. So Dr. Cassis, can you speak to some of the disparities that exist in oral health and how this bill might help address those disparities?
The bill helps in educating. We are so far behind in how we communicate with minorities and really everybody. I'd like to point out that pre-pandemic, the dentistry was in a good place. You know, we have the best infection control ever since the 80s. And after our mandatory shutdown, we came back busier than ever, and it hasn't let up. And what I'd like to tell the whole committee is that we see more minorities or underprivileged patients now than we ever have. So some of that has come out that, you know, it's safe to go to the dentist. And I would tell you, absolutely, if you're following the OSHA guidelines, we're in a great position for that. However, the bill itself will go so far into getting more minorities into the dental offices around the country. It's something I would highly endorse and would beg the committee to consider keeping that funding in place.
In addition to that, we need more dental offices in minority communities or in the medically underserved areas of our country. This is one piece of a larger puzzle, a very important piece.
Yes.
If there's a cost-effective way of improving health, is to increase health literacy. In this case, increasing oral health literacy is vital and very important in people to understand not only just the importance, but the practical way to care for their oral health, and to really make that association that your oral health is has a direct connection to your cardiac health. It has a direct connection to your other systems, organ systems, and so that's why it's so important to really put that in the forefront as well. So with that, I yield back my time, and I thank you for your work and bringing attention to this. And again, I thank my colleagues, Congressman Cardenas and Bilirakis, for putting this bill forward.
Gentleman yields back. The chair is pleased to recognize the gentleman from Georgia, Mr. Carter, for your 5 minutes of questions.
Thank you, and thank all of you for being here. Congressman, good to see you. I wanted to ask Dr. Radesky and Ms. Stewart, I'll ask you separately, but first of all, let me say, as you all know, the National Center on Birth Defects and Development Disabilities, this center works to detect, to prevent, and also to research birth defects and intellectual disabilities. And that's why I feel like it's crucial that we work on and pass my legislation that we're discussing today, the Improving the Health of Children Act. This would reauthorize this center for the first time since 2007, and I think it's extremely important that we do that. Ms. Stewart, I'll ask you first, why is it so important to have early diagnosis for birth defects and intellectual disabilities?
Well, thank you, Congressman. Well, birth defects are common, and they are also costly, and it's critical that we provide early detection and early treatment for babies. We've been a strong advocate at March of Dimes for newborn screening for many, many years, and we've been working in partnership with the National Center on a lot of these issues around birth defects. There are close to 8 million babies worldwide that suffer from a serious birth defect, and more than 3 million of them die before the age of 5. So, and there are a range of different birth defects that babies are sometimes dealing with in newborn babies, and the screening has to happen very quickly in many cases. Developmental disabilities, as you mentioned, around autism. The center has done an amazing job to really advance the research around the causes of autism, as an example. Many families that suffer with blood disorders, especially, for example, in the African-American community around sickle cell. The center's done an incredible job of advancing success there. And then it's not just babies with disabilities. When we identify those disabilities early in life, people are then dealing with those disabilities over a long period of time. And so the center's also been there to make sure that healthcare and programs are available for people to sustain them, to keep them active in life, and providing the care that they need to have an improved quality of life over a long period of time.
Great. So you would agree the center does need to be reauthorized?
Oh, no question about it.
Okay. Dr. Radesky, let me ask you, the center itself, do you feel like parents of newborns and with disabilities have easy and readily accessible access to the resources of the center?
You know, I'm not sure I'm qualified to answer that question. I can speak to my clinical experience with families of children with developmental disabilities. In general, find it very challenging to access resources throughout the community, whether provided through private or public sources. I just think, I don't know specifically about the center in question.
But you're saying your experiences are that in general, there is a problem with accessing any of the centers or any of the available options for these parents?
It varies depending on the family's health insurance and what is authorized in terms of treatments for things like autism or other developmental delays. Another factor is socioeconomic status or health literacy and other material hardships that impact a family's ability to, say, get transportation for early intervention or for therapies. And also just the fact that it is intimidating to coordinate and navigate all of these different therapies for your child, that I think some families feel very engaged and activated for, and other families find it confusing, overwhelming, and have a hard time engaging.
I appreciate your input on that because I consider you to be boots on the ground, if you will. And Ms. Stewart, what can we do to improve this? What do you think the solution is with a situation like she's describing?
Well, I think she's right in that every state, it varies, and every community varies in terms of the access of actual resources on the ground. I think what she's referring to are follow-up with experts and with specialists and others who can help in addressing those developmental disabilities. So there's a range of care. What the center really does is help to provide a lot of the surveillance and the data collection and the understanding of what kinds of birth defects and other kinds of health issues can be screened at the time of birth. But there has to be a better way of connecting that to the healthcare system and more resources, especially in low-resource communities, so they can access the care that they need, whether it's at home or
So how do
at
you
school.
do that? I mean, do you educate the caregivers? Do you educate the, not caregivers, but the healthcare professionals, the doctors and the nurses?
I think it's not only them, but you have to educate family members and you have to educate community members, school members. A lot of people don't know how to address these special needs, and without the level of awareness and the education that's needed, and frankly, the funding that many families need, if they don't have access to high-quality health care, they need additional resources to access the care that they may be looking for.
Great. My time has expired. Thank you all for being here today, and I yield back.
The gentleman yields back. Now, I need some assist from our staff because we have a series of 8 votes that are on the floor right now. Should we take Ms.?
Take Ms. Berrigan and go into recess.
Okay, so the chair is going to recognize the gentlewoman from California, Ms. Barragan, for her 5 minutes of questions, then we'll recess and I think have someone else Well, someone, we're going to have to recess because of 8 votes on the floor, and there's still members that are, that haven't had.
So we'll take a 2-hour.
We're going to take a 2-hour break. You probably, all the witnesses need a break. I'm sorry that we have to do it this way, but it's a compliment to each one of you that we've had such wonderful participation of committee members today, and that's what we want. So let's hear from, recognize the gentlewoman from California, Ms. Barragan, for your 5 minutes of questions, and then we'll recess.
Thank you, Chairwoman Eshoo, for holding this important hearing today on legislation that will advance scientific research, improve our public health system, and expand access to care for so many families across the nation. Maternal mental health conditions are a significant barrier for the health and well-being of women. In my home state of California, 1 in 5 California women suffer from depression, anxiety, or both while pregnant or after giving birth. Despite this high prevalence, 75% of impacted mothers never receive treatment. In addition, Black mothers are 2 times more likely, and Latina mothers are 1.5 times more likely than white mothers to develop depression during and after pregnancy. Ms. Stewart, how should maternity care, mental health care, and pediatric health systems work together to ensure the health and well-being of both the mother and child?
Well, thank you, Congresswoman. And the fact that we pay so much attention to maternal health care from a physical point of view really doesn't give the most attention that we need to pay to maternal mental health, which are the issues that you're addressing and you're raising, and we're grateful that you are, and your leadership on these issues. Maternal mental health challenges are some of the biggest challenges that many women face during pregnancy and after pregnancy. We know very, very much the issues of postpartum depression. A lot of people don't know, again, I think I mentioned earlier that maternal mental health is often one of the leading causes of death for women after giving birth to their child. And we're grateful that there have been some expanded resources. For example, there is now a maternal mental health hotline that the March of Dimes advocated for. The grant was just awarded by HRSA. That's a huge step forward. But we need to do more. We've been given a strong endorsement for the creation of a federal task force on maternal mental health through the Triumph for New Moms Act of 2021. We also are very supportive in the Momnibus of the Moms Matter Act, which is currently being reviewed by this committee, and it would also invest critical resources in maternal mental health as well. So one of the things that you mentioned is how stress and anxiety have an impact on maternal health outcomes and birth outcomes. That's especially true in communities of color that are dealing with issues of stress and anxiety, often brought on by the racism and discrimination that they experience in their own lives, especially in the course of bringing a baby into the world. So the issue of focusing on maternal mental health is really critical, and we strongly support all the efforts to improve and create more resources to address the issue, especially for women of color.
Well, thank you, Ms. Stewart, for your important testimony on this subject, for mentioning my bill. Certainly, given the significant impact of our families, I hope that the committee will consider my bipartisan Triumph for New Moms Act and other maternal mental health bills in the near future. Ms. Stewart, this next question is also for you. Lead in older homes remains a persistent problem for families across South Los Angeles. Roughly 2,000 children are diagnosed with unsafe levels of lead in their blood each year in Los Angeles County alone, particularly for communities of color where costs are a major barrier to access health care. Families are often unaware their homes could be a source of lead until the children are tested. Ms. Stewart, oftentimes federal outreach and education programs use language that is overly technical or does not resonate with the intended audience. Can you discuss why a federal advisory committee on childhood lead poisoning should provide culturally and linguistically appropriate outreach to communities of color to reduce the risk of childhood lead poisoning?
Well, thank you, and I'm aware of the recent issues in communities of color in Los Angeles with respect to, especially in the southern part of the city, with respect to children being testing positive for high blood levels, and it just reinforces the importance of passing the Lead Poisoning Prevention Act to invest more in resources and education outreach, referrals, and screenings for children that are testing positive for lead in their blood. It's also really important, and we've seen this in the pandemic, that the way in which we provide information to communities of color has to be culturally appropriate. It has to be done in conjunction with those communities so that it addresses language barriers, it addresses other barriers, and it especially addresses the trust barriers that exist in communities of color as well. So we would strongly recommend that all of the education outreach that happens be done in conjunction with those communities so that communities can receive it, understand how to use that information, and appropriately address the needs that their children may be having, especially if they're affected by high blood levels of lead. Thank you.
Gentlewoman's time has expired, and your comments about your legislation so noted, Congresswoman Berrigan. I'm going to stay because Mr. Curtis has been here since the beginning of the hearing this morning, and I want to call on him for his 5 minutes of questions, and then we will take a break. Mr. Curtis, thank you for your patience and being here for the entirety, and
Madam Chair, you're too gracious, and I'll go quick because we don't want you to miss the vote. And to our witnesses, we'll all shorten our answers if we can do this quickly. First of all, Madam Chair, thank you. It's been clear that this is an important hearing. I would just point out, I do have a bill. It's the Fixed Non-Disclosure and Health Research Act that I hope we can include in future hearings. I would have loved it to be included in this. In short, it requires NIH to report to Congress on funded research grantees that have ties to foreign governments. Ms. Stewart, maternal health care is important, and it's a priority for me as for so many here, specifically helping moms who are also suffering from substance use disorder. And I heard you talk about a number of conditions, but if maybe we could just touch on that one just a minute. I authorized legislation that required the Centers for Disease Control and Prevention to study the causes of opioid substance use disorder in pregnant and postmortem women, and that was the Poppy Seed Act. Have we improved outcomes for those expecting mothers and postmortem moms dealing with substance abuse disorders?
Well, I think there's, obviously the opioid crisis has had a severe impact on maternal health outcomes, infant health outcomes. We have seen a dramatic increase in the number of babies that are affected by neonatal abstinence syndrome. It is really a huge issue that we're facing. We have been a strong supporter of making sure, one, that we don't penalize women who are suffering from substance use disorder, that we find them treatment if they're pregnant or if they're a new mom, and also making sure that we identify those babies who are suffering from NAS and really need additional treatment as well.
Do you think the pandemic has hurt our efforts, and is there anything specifically you can think of that you'd like Congress to do?
I think there's no question the pandemic has created even more of a stress on the system with respect to mental health overall, and that is shown up in the ways in which the opioid crisis, even though we're not paying attention to it as much as we are the pandemic, it is still raging in this country, and it's affecting many, many families. It's affecting pregnant women. We strongly advocate to do more to make sure that women are able to get the treatment and the help they need as soon as they are able to, that they're able to stay in treatment because it's going to protect their lives and their babies as well.
Thank you very much. Quickly, Dr. Jones, I'm curious if we should be looking at preventive measures in addition to the steps you outlined in your testimony to reduce chronic heart disease in the United States. For example, I introduced legislation that would make it easier for small group plans and individual marketplace plans to invest in social determinants of health services, including offering, for instance, gym memberships as a benefit. Could you quickly explain if this would be helpful in addressing some of these chronic conditions?
Yeah, absolutely. As you're implying, cardiovascular disease remains our leading cause of death and disability, not only in this country, but across the globe. And we know what causes 90% of heart disease and stroke, and that's the traditional risk factors of cholesterol, blood pressure, diabetes, smoking, overweight, and all the things that actually happen upstream, those social determinants of health that are the causes of the causes. And so it's really critical that we apply all of our knowledge about improving social conditions, economic things, education, social and community context, and especially healthcare so that people have access to all of the tools that we know can prevent cardiovascular diseases and stroke. So amen to what you said. We need to do a much, much better job focusing on prevention. And in fact, it touches on so many of these other things. If we improve the cardiovascular health of our population, we see dramatically lower rates of cancer. We see much healthier mothers heading into pregnancy who don't deliver, unfortunately, either stillbirths or have adverse pregnancy outcomes or have children that start off on less healthy trajectories. So this is really the key to driving towards a healthier population. So very much support anything we can do in this regard.
Thank you. The chair has slipped out. I'd like to thank her, even though she's not here, for extending this for a few minutes. And appreciate everybody's patience and quick answers. Madam, I yield my time.
The gentleman yields. I will now recognize myself for 5 minutes. Thank you to all the witnesses who are here today and are hanging in there. And I want to thank the chairwoman who I'm replacing for the moment for this focus on children and families. There's two bills I'd like to speak on today. And the first is the Gabriella Miller Kids First Research Act 2.0. And Mr. and Mrs. Miller, I just want to thank you for being here today. Your experience with Gabriella is sadly one that far too many other heartbroken parents have also experienced, as you said in your testimony. And just yesterday, I spoke with the mother of a little girl named Danica, who was diagnosed with a brain tumor at age 21 months. And she died, sadly, last year at just 5 years old. And her mom, as she told me her tragic story and the family's tragic story, I thought about so many children with cancer who I've taken care of over 20 years as a pediatrician, and it's because of them and Danica that I so strongly support this legislation that will increase funding for pediatric cancer and rare disease research. The other bill that I'd like to talk about today is the CAMRA Act, and I really want to thank Dr. Radesky for being here virtually to talk about the importance of this research into the impacts that screens and screen time and social media have on our children. And so, Dr. Radesky, I first want to appreciate your highlighting that screen time is far too general a term, and that there's a difference between a FaceTime chat with grandma and grandpa and violent video games. And so I was wondering if you could first describe the family media plan that you created that helps pediatricians work with families to incorporate screen time in a healthy and balanced way.
Yeah, I'm happy to. Thank you. So when our American Academy of Pediatrics guidelines came out in 2016, we wanted to have more practical ideas for families who were trying to navigate this wild west of new technologies. And we thought that having really actionable ideas delivered through a kind of tailored digital format through the Family Media Use Plan on the healthychildren.org website would just help this be delivered a little bit more easily to families. We also wanted to encourage conversations that really get to the heart of when is technology a problem, when is it interrupting our family connections and our meals, when is it actually fun to do together and to tell us stories that make our lives more meaningful, when are we using it for our human needs. And so it represented that sort of balanced conversation, and we have found that tens, hundreds of thousands of families have used it, and we're actually updating it now because the research is constantly changing. The platforms that families are using are constantly changing, and we want to continue to be a resource for families, that's relevant on the ground, understanding the everyday tensions around this.
I know I appreciate that as a pediatrician, no devices in the bedroom, not at the kitchen table, et cetera. And I was wondering if you could give some quick answers, just a few words on each of these. Generally speaking, the effect on social media and video games on attention spans, specifically in school?
Yeah, there have been a couple of longitudinal studies. These are important because they look at how a child started off and how things change over time. And a few of the good ones have shown that the more frequent checking of social media, the more that children's everyday activities are fractured into different fragments by media use, that does impact attention span, and that it is not only kids who have pre-existing ADHD.
Thank you. And I will note, just in the interest of time, the effect of social media and video games on sleep, staying up too late, social interactions, the ability to communicate face-to-face, also between time spent on screens and myopia and obesity and learning. And yesterday I was speaking with one of your colleagues, Dr. Dimitri Christakis at Seattle Children's, and he noted that schools are spending a lot of money on buying devices, computers in the classroom, and that it's really not clear yet whether that is helpful or not. And so I would just like to kind of wrap up by saying that we need to be really strategic about screen time and media and our children. And the fact of the matter is that you are researchers and you still don't have access to the data that big tech does. And that is why the CAMRA Act is so important, to make sure that the NIH gets this data to guide us as pediatricians, teachers, parents, on our children's access and use of social media and screen time. Thank you, and I yield back. I would like to recognize.
So we don't have any members yet, so I would say that you can adjourn.
I will adjourn and call it. I will recess this committee. Do we have a time for recessing? The hearing will resume. Dr. Joyce has just arrived. That is all right. We are happy to have you, Dr. Joyce, and thrilled to resume the hearing. You have 5 minutes.
First of all, I want to thank Dr. Schreier, my colleague and my friend, for bringing us all together today, because this is an important slate of bipartisan bills that we are considering. I would especially like to note that H.R. 1113, the Carroll Act, named for the late wife of my friend and my colleague Andy Barr, and urge that it be marked up by this committee as soon as we are able to do so. Since March of last year, the COVID-19 pandemic has disrupted and upended lives in many ways that none of us could have ever imagined. Even with the staggering impact of this virus on public health, as a physician, I remain gravely concerned about the secondary effects that we will ultimately and continue to see. As the businesses and practices have shut down, routine cancer screenings, health checkups, immunizations were delayed and even skipped altogether. The delay in diagnosis of possible cancers and other health disorders will be something that we will be seeing and living with in the future. My first question is to Dr. Lloyd Jones. One of the other effects that we have seen is a staggering increase in BMI among school-age children. Dr. Jones, can you please speak about what impacts this will have from a general and from a cardiovascular health standpoint, and provide any recommendations on how we, as a legislative body, can address this?
Well, thank you, Congressman. This is a really critically important issue. And as you point out, we've looked at data that showed that 45% of Americans delayed routine health care in the summer of 2020, and it's still running around 20% saying that they're going to delay related to the virus and their concerns about coming into healthcare facilities. And that plays out in our children as well. As you pointed out, we've seen significant weight gains in Americans across the board during the pandemic because of changes in eating habits, because of forced sedentariness as we've been home more. And unfortunately, that plays out in the COVID-19. We saw that on average in the first year of the pandemic, American adults gained 19 pounds on average, which is really a striking setback to our public health. And that we've seen that in children as well. When children get obese early in life, it drives not only immediate metabolic changes, puts them at risk for type 2 diabetes, usually a disease of adults, puts them at risk for higher blood pressures, puts them at risk for worse cholesterol. And we know that each of those things is time dependent. The longer you're exposed to those things, the worse your vascular changes, the damage to your heart and your arteries, and the earlier the onset of those diseases will be in terms of heart attack and stroke. So it's really a tragedy that we're seeing much heavier children, and we were already one of the most obese nations in the world with regard to our children and our adults. But we're going to see this play out now over decades because it's so hard to lose the weight once it's been gained. And that will drive earlier and more rapid rises in blood pressure, blood sugar, cholesterol, and other metabolic problems that will play out. And we will see, unfortunately, increases in cardiovascular disease event rates and death.
Dr. Jones, I think you make an excellent point, and we will see this play out over decades. But immediately, right now, we've seen increases in overdose deaths, some of the largest in our nation's history. Losing over 95,000 Americans to overdoses in 2020 is an unacceptable number. And we need to work fast to reverse this deadly trend. In Pennsylvania, the availability of illicit drugs, specifically fentanyl, is a crushing blow to our local communities. We know these drugs are easy to get and fast to kill. During the COVID-19 pandemic, the opioid epidemic has further spiraled out of control. While Congress recently did just extend the scheduling of fentanyl analogs until early next year, we, as a committee, must make this ban permanent, and I would hope to see our committee activity on this life-saving policy very shortly. Thank you, and I yield back.
The gentleman yields. I want to thank you, Dr. Joyce, always my friend and my colleague, for raising such important points about both of those things, the opioid epidemic and children's health. I would like to now recognize my friend, Ms. Blunt Rochester from Delaware, for 5 minutes. You are recognized.
Thank you, Madam Chairwoman, for the recognition, and thank you to the witnesses for being here today to discuss the critical public health issues of cancer prevention, children's health, cardiac health, and oral health. The issues we are discussing today impact Americans of all backgrounds, but none more than heart disease. Heart disease is the leading cause of death in the United States, and by 2035, nearly half of the U.S. population will have some form of heart disease. If left untreated, heart disease can turn fatal because of serious cardiac events like heart attack, heart failure, and stroke. In addition to costing the country billions of dollars annually, serious cardiac events can also disrupt the long-term quality of life of survivors and families because of the physical, emotional, and financial trauma that accompany these events. Fortunately, we have evidence-based interventions like cardiac and pulmonary rehabilitation that can help those who have suffered get their lives back on track. Cardiac rehabilitation programs help patients recover more quickly by supporting them through supervised exercise training, emotional support, and lifestyle education. However, despite the clear benefits of cardiac rehabilitation, only 1 in 4 Medicaid patients eligible will ever receive it, simply because many patients are not being referred by their clinicians. Congress addressed this referral gap in 2018 by authorizing physician assistants, nurse practitioners, and clinical nurse specialists, advanced practice providers, or APPs for short, to supervise cardiac and pulmonary rehabilitative care beginning in 2024. APPs are already delivering this level of care. For example, some physician assistants order and supervise cardiac stress tests, pacemakers, and defibrillators, and some nurse practitioners already perform the care planning and oversee the care delivery for patients with complex cardiac conditions. But the question is, why wait? Let's remove the federal barrier. This is why I'm so pleased to be leading the Increasing Access to Quality Cardiac Rehabilitation Care Act, HR 1956, with Congressman Smith. This legislation will build on the previous success in 2018 and eliminate obstacles that prevent patients from beginning this critical therapy by allowing APPs to supervise and order these vital programs. I want to thank Dr. Lloyd Jones for his enduring support of this legislation. And can you elaborate on how allowing advanced practice providers to supervise and order cardiac and pulmonary rehabilitative care could decrease disparities in access for those in rural and underserved communities?
Certainly. Well, thank you so much, Congresswoman Blunt Rochester, and thank you for your sponsorship of this critically important bill. You know, APPs are people that we work with every day as physicians. They're highly trained, and they're really, you know, some people call them physician extenders, but they're much more than that, and they're a critical part of our healthcare system. Simply put, there just aren't enough doctors, and doctors aren't doing enough to order cardiac rehab in the first place for the 1.1 million heart attack survivors we have every year. And so we're talking about a lot of people here. So it's a lack of referral. We need APPs to be writing those prescriptions, and it's clear who's eligible for this intervention. We also need APPs because to start and maintain a cardiac rehab program, you need nurse practitioners, you need exercise physiologists on site monitoring the patients. But what you don't really need is a physician every time. Yes, you need access to a physician. They need to be, you know, available to be called if there's a problem. But APPs know exactly what to do if there's an urgent or emergent situation. They know how to call 911. They know how to administer basic life support, and they know how to give CPR immediately and often much more quickly and better than a physician could do if one waited around for the physician to arrive. So I think that's a critically important feature of this bill, and we're very much in support of it.
Thank you so much. And Dr. Dubois, I'm working on legislation to promote the use of preventive healthcare services like routine screenings and examinations, which have been delayed or foregone because of the pandemic. In your testimony, you note that we're still not back to pre-pandemic levels. Can you briefly elaborate on what the consequences of that may be for individuals and for our society?
Thank you. Well, that's a great question and a big concern of mine because the screenings did go down dramatically, especially each time we had the surges. It's really going to delay diagnoses, and that, you know, when that delay happens, it makes the outcome much worse because it's harder to treat these cancers when they, you know, present at a much later stage. We are trying to encourage everybody we can to get back in and get on their screening regimens. And it has improved considerably since the first surge, but it's still not back up to normal levels. And we're continuing to do whatever we can through our societies, through the press, public education, to make that happen. But anything Congress can do would be well received because this is still a problem.
Thank you so much, Dr. Dubois, and we are working on it. Thank you, Madam Chair, and I yield back the balance. I have no time, but I yield it back.
The gentlewoman yields. Thank you very much to my colleague, Ms. Blunt Rochester. I'd like to now recognize for 5 minutes the gentle lady from Minnesota, Ms. Craig.
Thank you so much, Madam Chair, and thank you to this committee for holding this important hearing this afternoon. Witnesses, just thank you for being here, for sharing your stories, your expertise. I have to say, though, a special thank you to Congressman Rick Nolan. It's so good to see you, and thank you for sharing your story and putting your pain and your family's experience in to progress. I know Katherine, just like you, was a woman of grit, a woman of love, of empathy, and just on a personal level, I'll never forget that last moment I saw you and President Joe Biden embrace just after Bo had passed away, and it just an enormous amount of empathy for what you and your family have gone through. You know, in Minnesota and nationally, lung cancer is the leading cause of cancer deaths. It's also one of the most commonly diagnosed types of cancer. Despite that commonality and lethality, we've made woefully little progress compared to other cancer types. We know that early detection saves lives, yet no-cost screening for lung cancer is limited, and those over the age of 55 with a history of smoking. In his testimony, Dr. Dubois points out that incremental progress is being made by the PSTF in recommending screening of lung cancer, which of course could be beneficial for women and African Americans who tend to smoke fewer cigarettes than white men, yet still have a high risk of developing lung cancer. Dr. Dubois, what other factors besides smoking history should be studied in women ages 40 to 49 to increase the scientific data available for policymakers like ourselves?
Well, thank you very much for that question. Some of the things that are related to increased risk in the younger population or secondhand smoke exposure, and some of that is not always collected properly or put into the record or documented to allow us to know what degree of risk that is. There's also things like radon exposure and other environmental exposures that increase risk in that younger population. And then there's also a segment of those individuals who have genetic risk factors and a history of lung cancer in their families that would need to undergo some genetic testing to sort that out. So there are other factors, and that is just one of the issues with the way the task force works. They really set things really based on age because they really look at the population as a collective instead of these individual higher risk groups.
Thank you so much. Congressman Nolan, I just want to ask, Katherine fought all the way through the very end of her life. Can you talk just for a minute about that fight and why she so strongly believed that she had such purpose at her end of life and the mantle that you've now taken up for her?
Thank you for that question. I could not have ever been more proud of her. She, I said earlier, she said that she would gladly go through all that she had endured, as so many others have, if it could result in the passage of this screening to provide early detection, because it's so critical in saving and extending lives. And in her final moments, we were with her. And she said, I said, Katherine, the great mystery is, for many of us, is not knowing what's going to happen to us here when our life is over. But I said, wherever that is, I want to be with you there soon. And you know what her last words and wishes were? She said, no, Dad, not until this bill gets passed. So I'm so grateful to the committee for considering this and the other important legislation, and in particular for beautiful young woman's last dying wishes to pass this bill, because she knew it would save so many lives. And she said she would undergo everything she's gone, including the finality of it in losing her life, because she knew it would save so many thousands, tens, if not hundreds of thousands of people, 465,000 people dying every day from lung cancer. Thank you.
Congressman, this committee looks forward to taking up this fight with you on her behalf. Thank you, and I yield back.
Thank you.
Gentlewoman yields. Thank you for those moving comments. I would like to thank our witnesses today for your participation in today's hearing, and I will submit the following statements for the record. The list here is provided, and with your permission, I will waive the reading of these. Thank you. Members have 10 business days to submit additional questions for the record. Witnesses, please respond promptly to any questions that you receive. At this time, the subcommittee is adjourned. Thank you.